Excellent. So we're going to talk about respiratory failure. Respiratory failure simply means that the respiratory system is not able to maintain adequate exchange of respiratory gas. The only reason we have a respiratory system is to be able to get oxygen into the body and get carbon dioxide out of the body, right? If the lungs and the respiratory system are not able to do that, then they are failing. Okay? If you're not doing your duties, you're failing. There are two types. There is the hypoxemic type. That means the problem is just getting oxygen in, carbon dioxide can leave. Right? And there is the hypocapnic type, which means you are not able to get oxygen in and you're not able to get carbon dioxide out either. Even though this is described as hypocapnic, usually it is also associated with hypoxemia. Alright? Okay? So, you understand that? So in hypoxemic, you only have low oxygen. In hypocapnic, you will have low oxygen plus high carbon dioxide. That is why we refer to this hypoxemic respiratory failure as type 1. It has only one abnormality. And the hypocapnic is called type 2 because you have two problems there. Okay? That is the way I teach it, but they just classify them like that. But you can use that to remember which one is type 1, which one is type 2. Okay? And now either of them can be acute. That means the patient's respiratory failure failed. What am I thinking? The patient's respiratory system failed in minutes. In other words, somebody was fine on their way to work this morning and on the freeway, they started having shortness of breath, and the next thing they passed out, and in the emergency room, carbon dioxide is like 60, oxygen is like 40. Like, what the heck happened? It was fine just when he left the house. That is acute respiratory failure, right? Or someone can come to you and say, oh, I've been having this shortness of breath now for some time. Say, how long? You say, a couple of months. So what happened? I don't know, I just started. And then you smoke. Oh yeah, I smoked about 2 packs a day for the last 40 years. Okay, so that is a chronic respiratory failure. So usually we're talking about minutes to hours. Here we're talking about days and months in both cases. The most important thing is for you to pay attention to those numbers. Even though on this slide it says PaO2 less than 60, generally speaking, we talk about somebody having issues. You don't wait for them to get a 60. By the bedside, you don't want to wait for anybody to get to 60. Whenever somebody's arterial oxygen content is less than 100, you begin to worry. Okay? Definitely less than 80, you want to start acting. Because by the time they get to 60, organs are shutting down all over the body. Okay? And there is something called multi-organ system failure. That is usually what you don't want. When you have hypoxia and it's been known for a while, everything starts shutting down. Liver start packing up, kidneys start packing up, the heart start having issues. Yes?
Is the PaO2 the unit you get on the pulse oximetry?
No.
No, it's different?
We'll talk about that. Yeah. The PaO2 is the arterial, is the oxygen content in the artery. Why are you sitting back there, man? You don't want to come to your spot? What is that? Oh, no, it's okay. Disrupt us, please. That's very considerate of you, but I like seeing you again. Right, okay, so the PaO2, remember, is the PaO2 from last lecture. Is the arterial PaO2, is the PaO2 of the blood you get from the artery. Okay? The 60% is what you get from the pulse ox. Okay? This one. And they say less than 60%. Yeah, in absolute terms, that is what it is. But clinically, you don't want to wait for the patient to get here.
So does that mean that that's all?
Yes, it's 60 or No. What it is if you have a patient on 60% FiO2 of oxygen and the pulse oximetry is less than 60, that is what it is. That's what the definition of hypoxemic respiratory failure is. In other words, the patient is on oxygen, 60% FiO2, and the arterial oxygen content is less than 60 millimeters of mercury. 60% FiO2, oxygen is 21% in the air, right? So when you start giving somebody oxygen therapy, you are giving them air that is richer in oxygen than room air. So that percentage refers to the fraction of inspired oxygen in the air they're taking in. All right. So the way this slide is exactly what it says. Arterial PO2 less than 60 on FiO2 of 60%. Okay. And then here is arterial carbon dioxide more than 45 and pH less than 7.35. Remember, carbon dioxide is an acidic gas, right? So when you hold on to it, you become acidic. When you let it go, you become alkalotic. Okay? Good, let's go. How do you get respiratory failure? This slide looks like totally confusing and complicated. Pay attention. Everything here is repeated over here, only now in pictures. So let's start with here, and I'll help you understand. I just put pictures here because I like pictures. I wonder if I have any space on the slide. On the slide, I always put some pictures there, okay, just to grab the point home. So let's start here. We already said that there are two types of respiratory failure: type 1 and type 2, right? Type 1 has 4 subtypes. Okay? There is the arterial hypoxia. There is the hypokinetic hypoxia, also known as ischemic. There is anemic hypoxia, and there is histotoxic hypoxia. You remember last lecture, I told you how things could go wrong, right? And we mentioned these different pathophysiologies and processes by which things could go wrong. Those are what we now translate into the subtypes of arterial, type 1 hypoxia. Of all these type 1 subtypes, the commonest one is the arterial hypoxia. Okay? So I'm going to dismiss hypokinetic, anemic, and histotoxic before I go to arterial hypoxia. Hypokinetic means the oxygen is getting to the blood normally. The lungs are working. But somehow, blood is not flowing fast enough to deliver it to the tissues. So the tissues are not getting enough oxygen. Not because the respiratory system is not getting oxygen into the blood, but the heart is not pumping the blood fast enough to deliver the oxygen in the blood to the tissues. All right? So that is why it's called hypokinetic. Kinesis is movement, right? Motion. Hypo means below standard, right? That is why it's also called ischemic, because it has to do with slow blood flow. Anemic hypoxia means that the oxygen is, the lungs are working, the oxygen is making it to the blood, all right, but there isn't enough hemoglobin in that blood to carry the oxygen. Okay? So I remember remember the equation for arterial content of oxygen? Remember that hemoglobin is part of it. 1.34 mils per gram of hemoglobin, remember? So if you have less than 15, which is the normal level of hemoglobin, that means you have less oxygen carrying capacity. So anemic hypoxia is usually due to low hemoglobin capacity, right? Histotoxic is usually due to poisoning of the cells. You remember the TCA cycle and the respiratory electron transport chain? At the end of the day, what is the end product? Oxygen ignites that what is that thing in the TCA cycle? That tricarbon. At the end of the day, what happens in the mitochondria is exactly what happens in your ignition spark plugs. Right? Oxygen and carbon dioxide. Oxygen and carbon collide, release energy, carbon dioxide is formed. That is really where that is happening. When you have cyanide poisoning, right? Something that poisons the enzymes in the TCA cycle in such a way that, yes, the respiratory system got the oxygen into the blood, the heart got the oxygen delivered to the tissues, the oxygen actually made it into the tissues, but the cellular system, the enzyme system responsible for utilizing the oxygen is poisoned. It can't work. That is what is called histotoxic. It is the failure of internal respiration. Okay? The one that happens within the mitochondria usually. Okay? So you see, this is not a big deal. Hypokinetic, anemic, histotoxic. They're just straight. Let's talk about this one. The arterial hypoxia. So, how can the respiratory system fail to deliver oxygen into the blood, the arteries? One is there isn't enough oxygen in the air in the first place, right? So that means the air that got to the alveoli did not have enough oxygen because there isn't enough oxygen outside. That will happen to you on Everest, right? Good. So that is what, because it is low level of oxygen in the alveolar air, as you find in high altitude, it is called alveolar hypoxia. Okay, it's very descriptive of what is causing it, right? Then the other subtype of arterial hypoxia is diffusion defect. That is, the oxygen was enough in the alveoli, but the membrane barrier is inflamed and so thick and scarred that the oxygen cannot diffuse across it. Right? So that is called diffusion defect. Poor oxygen diffusion across the alveolar capillary membrane. Then the other way it could happen is, the oxygen got into the alveolar, it crossed the alveolar capillary membrane, but it never made contact with the blood. Or it got to the respiratory bronchioles, and the bronchioles are filled with something, and it couldn't, and blood went through, but air didn't get there. That ventilation perfusion mismatch we talked about last week, right? That is another mechanism by which you can have arterial hypoxia. It is either dead space ventilation. That dead space ventilation is also known as a physiologic AV shunt. An AV shunt is an arterial venous shunt. An AV shunt is an anomaly that somehow gets blood from the arterial side to the venous side in a way that is not efficient, because under normal circumstances, blood from the venous and the arterial side don't mix. And the blood from the venous side is supposed to go through the lungs to make it to the arterial side, so it is renewed and refreshed. Anything that connects arterial blood and venous blood outside of the lung is a problem. But why is it called physiologic? Remember last week I told you that the VQ ratio is supposed to be 1. If the lung is a perfect machine, every alveoli that got air should get blood and should work well. But in the apex, there is more air than blood, so it's usually less than 1, right? And at the bases, Usually more than one because there is more blood than air, right? And in the region around in the middle part of the lung is about 0.9, close to what it should be, right? I remember I told you that even though the blood that comes from the apex of the heart has more, the BQ ratio is less than 1, and the one that comes from the base of the lung is BQ ratio is greater than 1. When they all get to the left atrium, everything mixes up and an average is reached, right? That is why it is called a physiologic AV shunt, because it is not really an anatomic connection. It's a functional, it gives you the functional result of what an anatomic connection would have been. Do you understand what I'm saying? So the end result is dilute oxygenation of the blood as a result of blood mixing from different areas of the lungs with different efficiencies. Okay? So it's a physiologic AV shunt. Why does it matter? Why do we have to distinguish it like that? Because there is another type of shunt called an anatomic shunt. That anatomic shunt is really anatomically a shunt. And the way it works, you're done with this, right? Okay. Remember that if this is a respiratory bronchiole, and this is an alveoli, and blood is, I'm not an artist, okay, so don't laugh at me. So this is my idea of air coming in here, right? And this is blood, right? Another normal circumstances, the capillaries, they surround the alveoli, air exchange takes place, and blood gets exposed, and this is the arterial side, and this is the pulmonary venous side, right? Under normal circumstances, this is supposed to be filled with air. But supposing you have that condition called acute respiratory distress syndrome, where I told you that the alveolar wall gets stuck together, right? Like those glass in the upper labella. What will happen is this system, basically because there is no alveolar wall, because the two walls are stuck together, in this particular unit of the alveoli, blood flows straight from the artery to the venous side, as if these capillaries just function primarily as a shunt, a real anatomic shunt, like the type you put in patient's arm for dialysis. Because the alveolar was collapsed and gone, right? Blood goes straight from the arterial side right to the venous side. So, if you understood what I just said, you will recognize that physiologic shunt and anatomic shunt are different severities of the same condition. Because in dead space ventilation, well, that just means, yeah, air got there, but blood didn't make it there. Right? In anatomic shunt, blood made it there, but air didn't make it there. Right? Okay. So whenever you talk about ventilation perfusion mismatch, you have to know which, in a mismatch, it takes two to tango, right? Either ventilation failed or perfusion failed. And you have to think in your mind, what are the things that can make ventilation fail? We talked about that last week. All of the alveolar filling disorders, right? Pneumonia, pulmonary edema, alveolar proteinosis, pulmonary hemorrhage, all those things. And what are the things that can make perfusion fail? Only one thing, pulmonary embolism. Pulmonary embolism, right? You remember that? I hope you do. Or do I need to start giving you a quiz every morning? Okay, I'll wake you up. All right, good. So do you see these are all the causes of this, right? Of type 1, yes, Wendy.
Can you go over the
Dead space ventilation means
Did you say air?
air got there, it was ventilated, air got there, but blood never made it there. So that place was a dead space. It did not participate in the exchange. Okay? Good. So this is clear, right? So type 1. Everything we'll be talking about is type 1 respiratory failure. Type 2 is easy. Type 2 has only 2 causes. So that's another good thing I want you to remember about type 2 respiratory failure. He has 2 abnormalities and he has only 2 main causes. Okay? Airway obstruction and hyperventilation. That's it. Those are the 2 main causes of type 2 respiratory failure. He has type 2 respiratory failure has 2 abnormalities, low oxygen, high carbon dioxide. He has 2 main causes, airway obstruction and hyperventilation. Now, the reason I put this cartoon here is to help you understand what do I really mean by hyperventilation. Hyperventilation is a big problem because it means the patient is not able to create the pressure changes necessary for airflow. Okay? It means the patient somehow is unable to generate the pressure difference required for airflow. Think about that. Let's think about that, how that could happen. If you are strung out on drugs with opioids, you're passed out, or for some reason you're in coma, you're not breathing, you're going to have to hyperventilate, right? If you have a high level cervical fracture, because your diaphragm, you guys are you doing anatomy already?
Yes.
Good. You know the C3, C4, C5 is the root of the diaphragm, right?
Yes.
So if you have a high a cervical canal fracture, like serious whiplash, and you transcend your cord at C3 level especially, that's where the main trunk is. You're going to lose diaphragm. If you lose diaphragm, you're not going to be able to generate the kind of pressure you need to breathe normally, right? If somebody cut your phrenic nerve with a stab wound to the chest, you're going to lose ability to, because the root of the phrenic nerve is your C3, C5. So that phrenic nerve injury can happen at the spinal level, or it can happen at the nerve level itself, right? Now, if you have a problem where your muscles are weak, as in myasthenia gravis. Myasthenia gravis is a disease where do you remember when we did pharmacology, we talked about neuromuscular transmission, and we talked about acetylcholine,
yes,
and the cholinergic receptors that are responsible for muscle contraction?
Yes.
Okay, good, I'm glad you remember that. In myasthenia gravis, people have antibodies against those cholinergic receptors. So acetylcholine is not able to make the muscles contract. So they are not able to, the intercostals and the respiratory muscles are not able to contract. So the person is not going to be able to generate the pressure difference needed for airflow. Good. And then, if somebody is pregnant, the baby is in the womb, pushing up against the diaphragm can't descend much. That is why you notice that pregnant women, they breathe shallow and fast, because the diaphragm is not able to descend because of the baby pushing up against it. That same thing will happen to somebody with ascites. You know what ascites is, right? Right? Excessive fluid in the peritoneal cavity is ascites. You see it in liver cirrhosis and in some other conditions, when there's a lot of fluid in the stomach pushing against the diaphragm. So you see, it's a beautiful thing. Or chest wall. Say somebody has a steering wheel injury and they fractured their sternum on both sides. In other words, the sternum is now, have you heard about flail chest?
Yeah.
Good. If you have any free segment of the chest, when you create a negative pressure, what happens? Instead of air coming in from the outside, that free segment part of the chest goes down. When you create a positive pressure for air to come out, that free segment part of the chest comes up. So you keep doing that, blocking the air from going out, blocking it from coming in. It's called flail chest. And it's a simple thing to treat actually. You just used to put a needle on it and hold it out so that air can go. And then you now tell the surgeons to do what they do, right? So do you see that it looks like a long list, but it makes perfect sense. In order for you to breathe, you have to have the brain, the respiratory centers, that their information must be able to get to the muscles. So it could be coma, you're not aware, or the information is not getting through the spinal cord to the nerve, or the nerve is broken, or the muscles are weaker than they should be, or the muscles have no room to move, right? All of that will give you hypoventilation, and it will give you type 2 respiratory failure. Okay? Now, airway obstruction is easy. It usually means that, well, the pressure, the respiratory system is able to generate the pressure difference you need to cause airflow, but the airway is obstructed, right? And it could be upper or it could be lower, like in laryngospasm, laryngeal edema, right? That is upper, teeth, tongue, and lower could be bronchospasm, as in asthma and COPD, right? Asthma being intermittent and recurrent, COPD being chronic, continuous, right? And you see, this one is just a complete repeat of what I told you under arterial hypoxia, talking about the normal VQ diffusion, telling you how the alveolar means that oxygen got here but it couldn't get past. Normal VQ means everything went through, and dead space means air got there but blood didn't go there. So this is the diagram illustrating everything we talked about here. And here is the shunt I told you about, this straight connection, blood just flowed right through without getting exposed to us. So this diagram is talking about this, and this one here is talking about the type 2. You see, it looks complex, but I believe this. Let me tell you what I'm thinking. I believe for your review, the less material you have to read through, the better and easier your review should be. Although each material is condensed, so this is a very dense slide. But if you understand it, at a single glance, you can remind yourself, so that's what I want. Make your own little note. You make your review easy. Am I thinking right? Mm-hmm. Okay. Excellent.
Question, Dr. Martin. So
yes.
Carbon monoxide poisoning, would that be?
Yeah, you tell me. Yeah. In carbon monoxide, what does carbon monoxide do?
It takes the place of oxygen.
Thank you. It reduces the capacity of hemoglobin to transport oxygen. So what would that be? Would it be isotoxic or anemic?
Anemic.
No, it will not be anemic because there is enough hemoglobin, it's just not available.
So isotoxic.
Isotoxic, it's a kind of isotoxic. It will cause isotoxic kind of hypoxia, right? Good, excellent. So this slide is clear to you now, right? Good, excellent. Let's move on. So respiratory failure. Patients don't come to you and say, Doc, my respiratory system is failing. That's not how they come. They come to you with a set of complaints. They tell you a story. You have to now make medical sense of what they're telling you, right? So, you see a patient, usually tachypnea means you're breathing more than 20. Okay? I don't know what others will tell you in that diagnostic class. They may say more than 30. If you wait for your patient to be more than 30, it's too late. Whenever somebody is breathing more than 20, none of you is breathing more than 15 right here, right now. Normal people breathe about 12 to 15. When you're breathing more than 20, that is when you want to begin to look. Because you see, on the inpatient service, big problems always start little. The reason they become real big problems is because nobody paid attention early enough. So in most of my classes, I will be giving you boundaries that are usually out of what you will be told in class. And the good thing is nobody tests you on those things. I want you to be very sensitive clinicians. Recognize trouble when it's far, so you can prepare for it and save your patient's life. Okay? So, tachypnea, if you're tachypneic, then you take a closer look and you see dyspnea. Dyspnea, how do you tell dyspnea from tachypnea? Tachypnea is just rate. Dyspnea is the effort. What is it taking this patient to breathe? If it's taking this patient to use all of his accessory muscles, he's not able to talk in full tenses. Like say, hey, how are you doing today? I have seen better days. He cannot even complete a sentence because the only way you speak in tenses is you take a deep breath, right? And then you control the release of that air through your vocal cord. That's how you speak. If you're not able to take a deep, if you're so short of breath that you need to breathe all the time, you can't do any control release for speech. So you begin to speak in very short tenses. You say, I am so sick of this life. I am so sick of this. I'm dying here. No. You understand what I'm saying? And that's a real patient, I'm telling you. So you see, when you look at your patient and you listen to them, you should be able to tell when somebody is on their way out, so you can really act really quickly. So you're talking about nasal flaring, the nose is going like that with your breath. Tracheal is going up and down like that. Supraclavicular recession, they are breathing, and every time they try to take a deep breath, their muscles, the supraclavicular fossa, deepens because of the intensity with which they have to create a negative pressure to breathe. Intercostals, if you expose their ribs, you could really count their ribs because the muscles are sucking in to breathe. The breathing is like a major workout. The abdomen is going in like that with every breath. That is not how people breathe. Tachypnea and dyspnea together is what we call respiratory distress. You see, if somebody has or somebody is in respiratory distress, that just means that they are doing a lot more work than they need to be doing for breathing. And because most of us, the human body is wired for survival, they will be able to maintain a normal blood gas at the beginning. But if nobody comes to their rescue, they will tire out. And when they tire out, that is when you will now see abnormal blood gas. So what am I saying to you? At the beginning of this lecture, I defined respiratory failure and I described it in terms of numbers. PaO2 less than 60 and FiO2 of at least 60%. That's what I told you, right? That is textbook, that is the exam. Bedside is you're looking at your patient. The guy is speaking in short sentences, is dyspneic, he's failing already. Even if his blood gas is fine, it's not going to be fine for a long time. You understand what I'm saying? So I'm teaching you now to differentiate clinical medicine when you're looking at the person in front of you and be able to tell it apart from biochemical and all this textbook stuff. There are two different kind of practices. Respiratory distress trumps arterial blood gas result any day at the bedside. You're looking at the patient, even if the lab called you, oh, the blood gas was normal. I'm like, something is wrong. When I was an intern, the lab got my patient sample. I was a resident actually. I sent the intern, he went there, the tech was not there. He dumped the patient sample. We're looking at the patient, I'm like, this guy is tachypneic, like 28. And the guy was sweating. And I'm waiting for the blood gas result. And then we got a call, and the lab said the blood gas was normal. Man, you guys messed up. This blood gas cannot be normal. This guy has been like this for the last 3 hours. What do you mean? It's normal. Repeat the blood gas. They switch the samples in there. Your patient, keep your eye on your patient. That's why you're a clinician. Okay? So extremely important. Now, respiratory failure is when you begin to see biochemical evidence of the respiratory system. So the difference between respiratory distress and respiratory failure is that a respiratory distress patient is in distress but is able to maintain a normal arterial blood gas because of his increased effort. When that effort is no longer able to maintain normal arterial blood gas, technically speaking, that is when your patient is in respiratory failure. Okay? And then, when your patient is about to die, then you begin to see abnormal respiratory patterns and rhythm. People don't just stop breathing. They start breathing weird, and then they stop. And these are all kind of rhythms. We don't do this in clinic, but when you connect a human being to a ventilator or something, or a dog to a machine, you can actually generate that kind of tracings of these abnormal patterns. So you see, this is a normal respiratory breathing. It goes up and down, in, out, in, out, in, out. Right? And then this is the tachypnic patient. You see, the frequency and the amplitude, the frequency is increased, but the amplitude is normal, right? This is a bradypneic patient. Here the amplitude is normal, the frequency is kind of a little less, right? This is your patient when they are not breathing anymore, okay? This is your patient just before. Chain strokes, in practice, chain strokes will come before apnea. You see chain strokes, apneustic, biot, agonal, shallow, these are all rhythm of death. Chain stroke is when your patient breathes like this. Then they stop. And then they take a series of breaths and then they cease. Take a series of breaths and then they cease. Really, let me tell you what is really happening. In chain stroke, the patient needs to breathe like this. But then they start getting tired. When they start getting tired, they start taking breaks in between those rapid breaths, right? And you notice that before the breath becomes shallow, then it ceases. So, chain strokes breathing is the respiratory rhythm of somebody who is about to become happy, who is about to just forget it, I'm out. Right?
Dr. Martin, can we see chain strokes in people with sleep apnea?
No. Sleep apnea patients, they will stop breathing, but usually they don't give you that variable amplitude. In chain strokes, they breathe in, out, normal depth. Then they breathe shallow, and then they cease. And then they come back, and then they slow down, they cease. Right? Whereas in sleep apnea, the guy goes, right. So that is these are all, I put this here, but the most important ones I want you to pay attention to: chain strokes, biots, apneistic, shallow, agonal, air trapping. These are all abnormal rhythm. Please, my prayer is that you will never see this, because that means you're going to sign a death certificate. Okay. Man, by the time people get there, very few people come back from that. All right, so now you know what you're doing. You've come about the causes of failure. If your patient goes into acute respiratory failure, there is no time for the body to respond. But the thing about it is, patients don't come to us unless it is really life-threatening. They don't come to you quickly. They always come late. So when there is respiratory failure for a long time, the body begins to respond to it. And the body does three things. The first thing the body does is increase the number of red cells. So So you get what is called a secondary erythrocytosis. Primary erythrocytosis is like Gilbert syndrome. You guys talk about that in hematology and oncology, right? No? You have not talked about it. Okay. Primary erythrocytosis is a red cell disorder. It's an increase in our red blood cells for no apparent reason. It's a pathology. Secondary means the body is trying to respond to something. So you have secondary erythrocytosis. It's a compensatory increase in the number of red cells in response to chronic hypoxia under the influence of erythropoietin from the kidneys. Okay, so it's erythropoietin. Secondary erythrocytosis is driven by erythropoietin from the kidneys. Okay? And then you know what has happened? There is pulmonary hypertension. Why do you think, Eva? The body is, no, that is not allowed, you must know. You have to
I know, I'm thinking, I'm sorry.
Okay, so think aloud. Think about it. What would the body raise the pulmonary pressure? Because it wants blood to flow through the lungs faster, so that oxygen can come through faster. And how does it do it? By causing vasoconstriction. Right? So you have a compensatory increase in pulmonary blood pressure. It's induced by hypoxic pulmonary vasoconstriction for a more even distribution of blood flow across the zones of the lung with uneven PQ ratios. Okay, so the purpose of this is to pump blood higher into the apices of the lungs, right? So it's more even to take advantage of those inefficient areas to make sure the blood gets everywhere equally so that oxygen can get into the blood and the body can use the oxygen. So it's an attempt to respond to inadequate oxygen delivery to the periphery. Okay? Then the unfortunate thing is that the body, the human body, is never a perfect machine. Whenever I try to fix a problem, something else breaks. So because of the increased pulmonary pressure, it causes pulmonary hypertension, and guess what? It put a strain on the right heart. Because now, yeah, the lungs are trying to get oxygen through, but then now they're stressing the right heart. Because that means the right heart has to now overcome that pressure in the pulmonary artery to get blood to go through the lungs. So what do you get? You get a right ventricular hypertrophy, and with the strain, and if that continues for a long time, the right heart fails. Whenever you see evidence of right heart strain as a result of hypoxia, that is what we call cor pulmonale. It's not cor pulmonale, it's cor pulmonale. Okay? That sounds like some African language. Okay, but believe me, it's not African. Okay, so all of these are responses. So when I ask you what is cor pulmonale, when we go to EKG and I tell you that is cor pulmonale right there, you will be able to tell why it may have been the case. Questions? We're good? Moving on. So how do you manage respiratory failure? How do you manage respiratory failure? You notice that for acute, I put treatment and evaluation. For chronic, I put evaluation and treatment. Because when your patient is acutely ill from respiratory failure, you have no time to find out what the cause of it. You need to get them stabilized first. Then you now start thinking, what the heck is going on with you? When they come in chronic, now you have time. They're not life threatening. You can do physical examination, oximetry, try to evaluate, and then treat the cause. Okay, so pay attention to that first. Now let's talk about the treatment acutely. The first thing you do is you want to give them symptomatic treatment. So that's the treatment, is symptomatic. Respiratory failure, symptomatic. Whenever the oxygen saturation, that is what a pulse oximeter measures, whenever it's less than 95, and or your arterial PO2 on your blood gas is less than 80, your patient has issues. Don't wait until it's less than 60. When it's less than 80, that is when you want to worry, especially on oxygen therapy. So you give them oxygen. How do you give oxygen? You will do this in diagnostic, whatever they call that class. But I'm just going to tell you, they may or may not repeat it, but this is how you do it. You give oxygen either by nasal cannula, by face mask, or by non-rebreathing mask. It's not luxurious options. There are times you need to do it by cannula, times you need to do it by face mask, times you need to do it by non-rebreathing mask, and I will describe that a little bit later. So whenever you want to give oxygen and you need less than 5 liters per minute, you're better off with nasal cannula. So in the air, oxygen is 21%. We know that. When you start giving people oxygen, you need to be able to compute what the FiO2 is based on the oxygen flow. Right? You're going to connect somebody to a cannula, you're going to connect them to a wall, and you're going to be cranking something on the wall at 1 liter, 2 liter, 3 liter per minute, and you're going to go. You better know when it comes to calculation, what is the FiO2 that you're giving that patient? You understand what I'm saying? So the way you do it is, for the first liter is 24%. So whenever you put somebody on oxygen, the FiO2 of the air they're inspiring goes from 21% on room air to 24%. Okay? For every additional liter after that first one, the FiO2 increases by 4%. Right? So if I have somebody on 3 liters per minute, their FiO2 will be 32, right? 24 plus 8, right? If I have somebody on 5 liters per minute, the FiO2 will be 24 plus 16. Right? 4 times 4, 16 plus 24. That's 40, right? You got it? Good. So the exam now, they'll tell you, anyway, you know how to calculate FiO2 and oxygen therapy. Now, when somebody needs to be on oxygen for more than 5 liters, and how do you know this? It's simple. Somebody is hypoxic, they're tachypneic and everything, and their pulse ox is less than 95%, you put them on 2 liters. On 2 liters, it's still 94, 95. You increase to 3 liters. And it's still not like 93, 94, you go to 4 liters. You keep cranking until you're able to get above 95, right? If you get to 5 liters per minute, and your patient is still under 95%, then you need to go above 5. Anytime you need to go above 5 liters per minute, you need to change your delivery method. Why? Because nasal cannula is dry oxygen. It's oxygen from the wall straight into the airway. It doesn't have any air in it. It doesn't have any water vapor in it. So once you give it at more than 5 liters per minute, it causes dryness and irritation of the airway. It becomes uncomfortable for the patient. And the reason we don't like to do it is because when the airway is dry, it cracks and it bleeds. You don't want to create more problem. The patient has enough. Right? So, whenever you need more than 5 liters per minute, you must deliver it by face mask. Face mask is also preferred in patients with COPD. Why is face mask better than cannula? Because face mask, you put it here. With face mask, room air and water vapor go in with that oxygen, because you're delivering that oxygen from the base, and there are openings around the mouth because it's not airtight, right? And water vapor goes in. So the air you're delivering through face mask is not as dry as you deliver in the nose. Okay? And what makes even cannula more dangerous is There is an area up here. Have you guys done ENT anatomy? Okay, there is an area up here that is very fragile, full of very fragile vessels called Little's area. Whenever you get nosebleed, you know they always tell you pinch the bridge of the nose. They want you to compress the Little's area. Little's area is where most people bleed from when you have nosebleed because they have this fragile blood vessels over there. They get dry, they break, and they bleed. Okay, so when you give oxygen by face mask, you give it's a little bit more humid oxygen, right? You prefer it whenever you are going to deliver oxygen at 1.5 liters per minute, but specifically and more importantly, we like to give oxygen to COPD patients by mask because COPD patients, they have a very unique abnormality. You see, under normal circumstances, the respiratory center, they rely on PCO2 level to gauge respiratory effort. It's the carbon dioxide that really determines how fast you breathe in and how deep you breathe. Not oxygen, it's the carbon dioxide. Because the respiratory centers are wired to respond to ventilatory effort. Okay, so under normal circumstances, the respiratory centers are more sensitive to PCO2 level. When you have COPD, you hold on to carbon dioxide. Okay. Because you hold on to carbon dioxide, your respiratory center becomes numb to carbon dioxide level because it's been around so long, so much. It doesn't depend on carbon dioxide anymore to gauge ventilatory effort. It begins to rely on oxygen. Okay? So they have, so in clinical terms, we say COPD patients have hypoxic drive. Okay? Normal people have hypercapnic drive because their respiratory center tracks carbon dioxide level. But because in COPD, the carbon dioxide level is high most of the time, the brain switches to oxygen and it begins to have hypoxic drive. Now, think about what happens. So if a COPD patient come in and they have hypoxic drive and you give them too much oxygen, what will they do?
Stop breathing.
Thank you. And that's what it's called. That's what it's called CO2 narcosis. It will just stop because there will be so much oxygen in the blood, the respiratory center will say too much breathing and it will cut it off. The patient will stop breathing right there. So that is why you have to be very careful with oxygen therapy in COPD patients. You don't give it by mask. You don't give it by cannula. You give it by mask. Because by mask, you're able to dilute the oxygen with ambient air and water vapor. Because you don't want carbon dioxide narcosis. Narcosis means the patient falls asleep right on you. Okay. Now, when do you use non-rebreathing mask? Anytime you are giving somebody oxygen and you've given enough oxygen to generate 50% FiO2 and they're still not responding, then you need a non-rebreathing mask. What flow would you need to generate to give somebody 50% FiO2?
15 liters.
Thank you. That is important. Yeah. Once you're over 10 liters per minute, and your patient, because at 10 liters, that is like what? 4 times 9 is 36 plus 24. That is like what? Almost 60, 70, right? Mm-hmm. Yeah. Once you're over 10 liters per minute, and your patient is still not responding, that is when you need non-rebreathing mask. What is a non-rebreathing mask? It's a very interesting, simple device. I hope they have it in yellow in your diagnostic class. I'm going to come there to make sure they do, because you need to see it. It's a very simple device. I used to bring one here. It's a mask, right? You know I'm not an artist, so bear with me. It's a mask. This goes on the patient's nose right there, right? And the oxygen is delivered into a bag, right? And up here is a valve. And around the nose is this padding that makes it airtight, right? Remember, it's called a non-rebreathing mask. The reason it's called a non-rebreathing mask is it has devices that discourage you from rebreathing the air you breathe out. Okay? So what it does is, it has these perforations, and above these perforations there is a flap. Okay? There are perforations and there is a flap. Right? And here is a tube and there is another flap. When the patient takes a deep breath, the patient creates a negative pressure within that mask. That negative pressure sucks down the flap and closes these openings, and at the same time sucks open this flap right here, so that oxygen goes into the patient's nose from the bag. When the patient breathes out, the patient creates a positive pressure within that mask chamber, and that same positive pressure now pushes these flaps open, so the patient exhales outside and closes this one, so the patient doesn't breathe in the back. So by this method, you're able, that's why it's called a non-rebreathing mask. And what makes it a non-rebreathing mask is the bag flap device that I just described. Okay, when you say it, it makes more sense, very simple. Yeah.
Could you explain to me again, like when you would decide to use a non-rebreathing mask? I didn't get the numbers.
More than 10 liters per minute.
More than 10 liters?
Whenever your FiO2, if you're giving somebody up to 50% FiO2, so what flow would you need to have to deliver FiO2 of 50?
15?
15, exactly. So whenever you are giving somebody more than 15 liters per minute, and I'm saying don't wait until 15. Once you're giving somebody 10 liters per minute and they're not responding on mask, go straight to non-rebreathing. Okay? Yeah. So I hope you're following this. The clinical implication of this is that you have to keep your eyes on the patient. You know, you give him cannula 2 liters, you come back, look at the pulse ox. It's not responding, you crank it up 4 liters. You always double. Don't go from 2 to 3. Come on, go from 2 to 4. Right? If it's not working, you need to go to 6 now. Tell the MA or whoever is there, change that to a cannula, put him on 6 liters. You come back 10 minutes later, the guy is still not doing anything. Go to 8. You keep doing it. Once you're above 10, and the guy is not responding, say, get me an RT, not rebreathing mask. And now you're standing by the bedside. Because if your patient is not responding to non-rebreathing mask, they need to be intubated. Okay, so that is what that is. And you see what I say here? Whenever your patient is not responding to a non-rebreathing mask, they need ventilatory support. And ventilatory support is indicated when PaO2 is less than 100 on 100 of FiO2. Yes, Christian?
So you're saying that you would go, like, once there's no response to these 3 methods, you would go straight into intubation?
Yeah.
You wouldn't, like, use BVM first and, like, try to use them?
Well, the thing about it is not many places have this kind of facilities, and moreover, those decisions as to whether to use ventilatory support systems and positive airway pressures and stuff like that, you are usually not trained to know the different types and when to use them. So what I would recommend that you do is, whenever you are putting your patient on FiO2 of 100 and PaO2 is still less than 100, they're going to need some kind of ventilatory support. That's when you want to call RT and your pulmonologist. They will come and assess and decide what mode and everything, and then they will recommend you. You understand what I'm saying? Yeah. Okay, so, and always the patient benefits. If you think that this failure is coming from airway obstruction, you can always give them bronchodilator and then you evaluate them. Okay? So this is clear, right? Good. You must know how to compute FiO2 on oxygen. You must know when to switch to a face mask. You must know how non-rebreathing mask works. When should you call your RT and get ready for intubation? Bronchodilator never hurts anybody.
Question.
Can you explain why it's preferred for COPD patients again?
Because they have hypoxic drive. When you give by nasal cannula, much of the oxygen you're giving goes straight to the airway. But when you give by ordinary face mask, there is air going in with that oxygen from the surrounding around the mask. So the FiO2, the amount of the air is not, the oxygen you're giving is not as dry because it has water vapor, nitrogen from the atmosphere that is going in with the oxygen. Yeah. So you want to give less FiO2 of oxygen by giving diluted oxygen because you want to preserve the hypoxic drive. Remember, you want to keep them a little bit hypoxic so the brain doesn't think that they don't need to breathe. So you cannot keep them enough oxygen to. So in a COPD patient, you'll be happy with 92. You don't want to push them to 100%. 92, and you keep managing it little by little. In a COPD patient, you will not go from 2 to 4. You will go from 2 to 2.5, 3. Because especially when the guy comes in like this, it's not because he's been working out. It's because he has air trapped everywhere and he's in trouble. Yes, Karen?
So it's the humidity that you want for COPD patients, right?
Yes, you want the dilution of the ambient air.
So could you do a nasal cannula with the humidifier?
You can, yeah, well,
Kind of like in our facility.
Usually-
that's an option too. Like, would I use that for a COPD patient or no?
because in the hospital, we don't have that setup where you have cannula and humidifier. You have a warm oxygen and it's dry oxygen.
Yeah, and then you could attach a humidifier too.
You can attach
Yeah.
humidifier to it, but there is another problem with that. How do you gauge, when you attach your humidifier to the cannula, how do you compute your FiO2? Remember that these are clinical situations. You have to make decisions based on numbers. And you want to make sure the numbers are clean numbers. It will be okay to attach it, a humidifier to it, but then your calculation will get all messed up and everything. You'll be wondering, okay, how do I compute the FiO2 with the humidifier? I've not really done that before.
I was curious.
Yeah, but it makes sense. It's a good thing. Yes, brother.
So if somebody's not keeping it currently, right? Because I've seen like COPD patients walking out of the oxygen tank and they have a nasal cannula, like just to go about the day. So that would be different if they're chronic, they can have a cannula.
If you look at every COPD patient right around the tank, look at the flow. It's usually 1, 0.5. I have very low flow. And there are specific indications for that. Home oxygen, we'll talk about it when we talk about chronic obstructive airway disease. Okay? How is it? Excellent. So you see, for chronic, you have time to evaluate them, put them on pulse ox, you will do blood gas, and you can do pulmonary function tests to kind of figure out what the heck is going on with this patient. So, what are the pulmonary function tests you can do when somebody is in respiratory failure? Well, you can determine lung volumes and capacity, and you can determine lung resistance and compliance, and you can evaluate the alveolar capillary unit. Pay attention to that. Your lungs function as gaseous exchange chambers. So you will assess how much space there is in the lungs by assessing lung volumes and capacity. You will assess the airway. Is the airway patent and free? So you assess the resistance and compliance, and you do that with spirometry, and then you will assess the integrity of the alveolar capillary membrane. And the test you will do for that is the diffusion capacity of the lung. Usually you use carbon monoxide for that, and it is called DLCO. is the diffusion capacity of the lungs as measured by carbon monoxide. So, the method you will use to measure lung volumes and capacity depends on the kind of lungs you have. If you have pulmonary bleb or bullae, they are both the same thing. The difference is in their location. And basically what they are empty air spaces. You see, like the lungs begin to look like a honeycomb, right? And normal lung is supposed to have alveolar receptors and everything is supposed to be clean, you know. So this is my mathematical representation of the alveolar, right? So each of these is an alveolar, right? When you have a bullae, you have lost alveolar septal wall. So instead of having fine air cavities that are efficient for air exchange, walls are broken down and you have all these cystic air spaces within the lung. That is what a bullae is. When it happens closer to the surface, in such a way that the only thing covering it is the pleura, that is a bleb. Why is it important to know the difference between a bleb and a bleb is close to the surface. If this person sustained blunt trauma to the chest, a bleb can rupture and give you pneumothorax from blunt trauma. Okay, so bleb tends to be on the surface, bullae tends to be within, but they are gas chambers. If the patient's lung is fine and there are no blebs, no bullae, you use what is called the nitrogen washout or helium dilution technique. Okay? But where there is, I want to say something? Where there is blebs and bullae, you have to use a different technique called whole body plethysmography or plain X-ray planimetry. Okay, these are exam stuff, not much. No, I've never sent anybody for lung volume in my life. For the 28 years of medicine I've practiced here. Because invariably I know what is going on from the examination. All right, so you always test lung resistance and compliance with spirometry, and you do that. And whatever you find, you treat. That's about that. Good? So, pulse oximetry, Karen. So how does that really work? You see, pulse oximetry is actually based on the fact that oxyhemoglobin and deoxyhemoglobin, they absorb light differently when they are exposed to infrared and red light. So what you do, what that pulse oximeter does, is once you turn it on, it shines both red and blue infrared light. And then the computer uses the relative absorption of the red and the infrared light and compute what fraction is oxyhemoglobin and what fraction is deoxyhemoglobin, and it spits out a percentage. Okay? So, it assesses hemoglobin saturation based on the relative red and infrared light absorption features of oxyhemoglobin and deoxyhemoglobin. And I told you, oxyhemoglobin absorbs more infrared than in the 850, 100 nanometer wavelength, and deoxy absorbs at 600 to 75. I show that here, right? And then the computer generates a percentage for you, so you know what the amount of saturation is. What is important that you know is that once you see somebody with an oxygen saturation of 95%, you will get that when saturation, the machine measures saturation with 95% confidence interval when saturation is above 75. So basically what I'm saying here is, when you see saturation, when somebody is sat in 90, that means their real saturation could be anywhere between 85 and 95. 85 is not a problem zone. 95 is not a problem zone. 85 is. So don't depend on the SAT alone. Look at the patient. So if you are looking at a patient that is in respiratory distress and the saturation is coming back 95, who would you believe? Exactly. So you see, I see this a lot. I don't know why this patient is short of breath, Dr. Martins. He's sat-in 95, but it's flaring. And not because that is not 95, that is truly 85. That machine, it looks at 90 with a confidence interval of a very wide confidence interval, 85 to 95. So when your patient is sat in 90 by the bedside, but they look like they are distressed, you should begin to wonder this is the patient that is at the lower end of this spectrum. Okay? Excellent. It's very useful, it's very helpful, helped us tremendously in critical care, but it's not a perfect thing. It will underestimate saturation if somebody is in shock. And you can understand that. Shock means low blood pressure. Well, if blood pressure is low, that means blood is not flowing. So if blood is not flowing, your pulse oximeter does not have enough blood to really give you an accurate assessment of the saturation, right? So if somebody is in shock, don't depend on pulse oximetry. You have to do a blood gas, okay? If somebody has peripheral edema, they are swollen, the distance between the skin and the blood vessel is thicker and longer, right? So your pulse oximeter is not going to be accurate. In people of African descent with hyperpigmented skin, it's less reliable also. So you pay attention to your patient. When your patient wears a blue and black nail polish, the machine gets confused. Okay? And then when you have methylene blue infusion, or you are in xenon light, in the OR they use xenon light because it doesn't cast shadow, right? That xenon light confuses the machine and creates a lot of problems, right? And then motion artifact. The patient having a seizure or they're having cardiopulmonary resuscitation, all of that can interfere with the way pulse oximeters work. And pulse oximeters can overestimate, can fool you under two conditions that you must know. This pulse oximeter is not able to differentiate between carboxyhemoglobin and oxyhemoglobin. So when somebody has carbon monoxide poisoning, the pulse oximeter will report the oxygen saturation as a sum of oxyhemoglobin and carboxyhemoglobin. So it will give you a very high number in a patient that is dying. Okay? And the same thing with methemoglobin. When you have methemoglobinemia, right? And that comes from some antibiotics that we use. When you form methemoglobin, the machine cannot differentiate between methemoglobin and oxyhemoglobin. So it gives you super high levels in the patient that may be sick. Okay? All right, moving on. So blood gas. You do a blood gas. Katie will teach you how to do blood gas, and you will do stuff down there. We're upstairs, downstairs, yeah. So you do a blood gas. You know your patient is in respiratory failure, and you need to know whether he's type 1 or type 2. You cannot know if he's type 1 or type 2 if you don't do a blood gas, right? So the first thing you do is to do a blood gas. If on your blood gas you see a low PO2 and a normal PCO2, that means your patient has type 1 respiratory failure. Now, remember type 1 respiratory failure? It could be arterial, ischemic, right? Or hypokinetic, isotoxic, anemic. Blood gas does not help you with isotoxic, anemic, or ischemic. Blood gas doesn't. Those are clinical things. If your patient is in dilated cardiomyopathy and now they are low pressure and they have hypoxia, you know that is hypokinetic hypoxia, right? You don't need a blood gas to diagnose that. The real reason you do a blood gas is to evaluate that complicated arterial hypoxia. Remember, arterial hypoxia, the one that has all those subtypes, right? Alveolar hypoxia, diffusion defect, PQ mismatch, anatomic shunt. physical is all subtype of arterial hypoxia. So blood gas, the real reason you do blood gas to evaluate the type of hypoxia is to figure out what subtype of arterial hypoxia the patient has. Okay, so this portion of my lecture is telling you how do you use the information from the blood gas to figure out the subtype of arterial hypoxia that the patient has. So the first thing you do, you compute the AA gradient, and you're all masters at calculating AA gradient now. Is that right? Right? Good. If you compute AA gradient and AA gradient is normal, that means your patient has alveolar hypoxia. Because that means the lungs are fine. Whatever got into the alveoli got into the blood. So the lungs are fine. A normal AA gradient generally means lungs are fine. Good. If your AA gradient is wide, then there is a problem. If your AA gradient is wide, then the next thing you do, you see, does the patient respond to oxygen? So basically, you do the first blood gas, and you see a wide AA gradient. You now put the patient on oxygen, usually 100% oxygen. You wait about 30 minutes to an hour, and then you repeat the blood gas. If your patient responds to oxygen, that means they have either a diffusion defect or a VQ mismatch. Right? Those are the two conditions. If they don't respond to 100% oxygen, they have shunt, ARDS. Okay? Now, I'm going back up. If your patient responds to oxygen, it is either diffusion defect or VQ mismatch. Diffusion defect is complicated, difficult to figure out. It's a special test. The patient has to go to a lab. They have to do special things. When your patient is acutely ill, you always go from the simplest test to the most complicated test. So whenever you have a wide AA gradient, the first thing you will do is, do we have a chest x-ray? If chest x-ray shows bilateral pneumonia, there's your answer right there. Right? It's a VQ mismatch, dead space ventilation because of the pneumonia. Right? If chest x-ray is normal, chest x-ray is normal, that means the air is getting to the lungs. Then the problem is the circulation. If you're in a rich place, you will do a spiral CT. If you're in a low-income poor neighborhood, poor country, you probably will do a VQ scan. Okay? The gold standard is spiral CT. VQ scan, it's okay for low-income countries. Okay? Like if you're in Burundi, you probably will do a VQ scan. If you're in Westwood, you probably order spiral CT. Okay? But it's always what is available. What I'm saying to you is, don't go to Burundi and think they don't have spiral CT. Ask, we need a spiral CT. And they'll probably tell you, oh, sorry, we don't have spiral CT. But we have a VQ scan. Okay? So do you see what I'm saying to you? You do a blood gas, compute AA gradient. AA gradient is normal, your patient has normal lungs. They are in some place where they need to get away from that place because it's alveolar hypoxia. Wherever they are, enough oxygen is not getting into the alveoli. If AA gradient is wide, say give them oxygen, 100%, repeat the blood gas, call me back. Oh, you respond to oxygen, okay. Does he have a chest x-ray? Oh, chest x-ray is clean, get a spiral CT. Because now you're thinking VQ mismatch, right? If spiral CT comes negative and chest x-ray is clean, and you still have wide AA gradient with response to oxygen, then you have to say, okay, fine, we're just going to treat symptomatically, and when the patient is stable, we'll send for diffusion. We'll send him to go and get DLCO. Okay? To measure the diffusion capacity of the alveolar capillary membrane. Okay? And no response to oxygen, that is ARDS. This one you're calling the ICU. Okay? Usually, I mean, when you do emergency room rotation, you will see that. You guys have a bed, have a guy in ARDS, right? Because that's where they're going to go, because you're going to intubate them. Okay. So you do blood gas. Now let's say on your blood gas, even though we talk about blood gas, we talk about pH, PCO2, bicarbonate, and PO2, and oxygen saturation. I need you to remember that the only true blood gases are PO2 and PCO2. The pH and the bicarb, they are indices of the acid-base status of the patient. Okay, so when we do blood gas for respiratory failure, we make our decision purely on PO2 and PCO2. The pH and the bicarbonate we do not to assess the respiratory failure, but to see how bad it is. Like if somebody doesn't have oxygen, they're going to form a lot of lactic acid. They will become acidotic, right? So the pH and the bicarb gives you an idea of how bad this hypoxia is affecting this patient. So it is often bundled together. But my conversation with you today is going to center only on PCO2 and PO2. Okay? When we get to acid-base disturbances, I will talk about that. And you guys will repeat it again in nephrology. But by the time you get to nephrology, you'll be experts. That lecture in nephrology will be very easy. Okay? Good. So now, this is what you do with blood gas in type 1 respiratory failure, right? Now let's say you do your blood gas and you find that oxygen is low and carbon dioxide is high. That means the patient has type 2 respiratory failure. And there are only two causes for it. Hypoventilation and airway obstruction. If AA gradient is normal, your patient has hypoventilation. If AA gradient is white, your patient has airway obstruction. Simple. And remember, I already told you how to estimate AA gradient. I gave you a number, actually. I gave you a number 10 to what? 30 to 50, more than 50, right? Now, that is number average, but the reality is that AA gradient depends on your age. So, 30 might be normal for an 80-year-old man, and 30 will be severe for an 18-year-old man. So, that number I gave you is for you to know for exam. By the bedside, you always estimate the patient's AA gradient from their age. And the way you do that is you divide their age by 4 and you add 4 to it. So in a 60-year-old man, the AA gradient should be about 1920. Okay? In a 10-year-old kid, the AA gradient should be about, no, 12-year-old kid, the AA gradient should be about 7. Right? So you always estimate it based on the age. So remember these formulas are critical. FiO2, 24% for the first liter, 4% for every other liter. Alright? AA gradient, 8 divided by 4 plus 4. Very important that you kind of carry those in your head. Alright? Before you do a blood gas, Katie will talk about this. Before you do blood, because in blood gas, you're going to stick a needle in somebody's artery. And part of the complication of doing that is going to be thrombosis of that artery. Some people have anatomic anomalies. Everybody is supposed to have a radial artery, and an ulnar artery. But supposing you didn't know, and your patient has only one radial artery, and maybe they are missing ulnar artery, and you went and stuck a needle in there to do a blood gas, and the artery thrombosis and get clot, the hand will turn blue immediately, and the hands will fall off. So before you do blood gas, you want to do this test called Allen test to make sure that the patient has an ulnar artery that is open and connected to the radial artery through distal anastomosis. Okay? So how do you do it? You put your finger on both, right? And you tell the patient to clench their feet a number of times. By doing that, when you look at their hand becomes white, right? When the hand becomes white, you now release the ulnar pressure and see how quickly it feels. The hand turns back red. Okay? So you occlude both, you you can actually do it on yourselves, but this is not a class for that. Okay. So you occlude both radial and ulnar artery, you have the patient clench, the hand turns pale, then you release the ulnar and you watch the hand color return. That is an evidence of intact ulnar collateral circulation. That is your green light for blood gas in the radial artery. Okay? I talked about determining lung volumes, and I told you that we determine lung volumes and we add volumes together to develop capacities. My next few slides, they look complicated, they look like difficult. Let me ask you, let me prepare you for them. It is very simple. Very simple. All of my slides, my next 3 slides, they are based on 2 things. I have a substance X in 2 chambers. In one chamber, I know the concentration or the percentage of X. No, actually, in one chamber, I know the amount of X. Because I know the concentration. For you are the one, I use the volume of distribution, the well example. Okay, the same principle. I know the concentration of X, and I know the volume of this chamber. So I know the amount, right? If I and say I don't know the volume of this space, I know there's a compartment here, but I don't know the volume of it. If I'm able to get X to be in equilibrium with this cavity, and I have access to measure the concentration of X in this cavity, I can determine what the volume of this cavity is. Right? Because the amount of X here and the amount of X here will be the same once it is in equilibrium. Right? Exactly. So exactly the same thing here. How do we determine lung volume, or which lung volume? You have your patient breathing in and out in the tidal space, right? As they're breathing in and out in the tidal space, the air they're bringing in and the one they're exhaling is getting equilibrated with their expiratory reserve volume and their residual volume, right? That functional residual capacity, right? Remember, that is functional residual capacity is the sum of residual volume and expiratory reserve volume. So if your patient is breathing air in the tidal space, they're not taking any deep breath, just quiet, gentle breathing in the tidal space, the air will be equilibrating with the amount of air in their lungs. Okay, so if I have a patient breathing in oxygen through one-way valve system, that means the air is not coming back. These 2 diagrams are telling exactly the same story. I just like this one because a little bit more complicated. I put this up there to introduce you to the concept. Okay, so the patient is bringing in oxygen through one-way system. That means oxygen is going to go this way and it's not going to come back here. And in this lung, we don't know what the volume is, but we know that there is nitrogen here because it's room air, right? And the percentage of nitrogen in room air is about 79 point something percent. We approximate it to 80, right? So I know the amount of nitrogen in this gas here, but I don't know the lung volume. Now I'll now collect, as the patient is bringing in oxygen, because this is 100% oxygen, I will be diluting the amount of nitrogen here, right? With every breath, more oxygen comes in, and the space available for nitrogen is less. Remember Dalton's law? Good. So more oxygen, less nitrogen. More oxygen, less nitrogen. Over time, and I'm collecting all of that nitrogen here. So now, I've collected nitrogen over here. I know the volume of air in this place because I collected all of it. I know the concentration of nitrogen in this place because I could measure it. With the volume of air and the concentration of nitrogen in this space, I can compute the amount of nitrogen I have in this space. And that must be equal to the amount of nitrogen inside my lung, right? I know the concentration of nitrogen in the lung because it's the concentration of nitrogen in room air. Then I can figure out what the lung volume is. You see that?
I get it, but yeah.
You got it? I mean, it's simple. It's called dilution technique. Just the same way we estimated how deep is this well, or what is the volume of water in the well. When you get a volume of X and the concentration of X, you drop it in the well. You now fetch water from the well and find out what the concentration of the substance is in that well. Since the amount is the same, you only need to divide the amount of X by the concentration of the substance in the well, and that gives you the volume of the well. Okay. The same way, you use oxygen to displace nitrogen, you collect all of the nitrogen and its volume, that equals the amount of nitrogen in the lung. The amount of nitrogen in the lung is the concentration of nitrogen in that air plus the lung volume, the functional residual capacity. Okay? So I just do the math. And this is just a diagram telling you, as I give the patient oxygen, the nitrogen dips, right? The important thing is that you have one-way valve system that ensures that you don't breathe the oxygen. So these two diagrams, this is a simpler one, but I wanted to give you an idea of how complicated the process is with this one. Are you clear? Just remember the well example. You have a well. How do you know how much water is in that well? Well, that's simple. Get a dye. You know the volume of the dye. You know the concentration of the dye. So you know the amount. Dump that entire content of the dye in the well. And then the dye will distribute in the well evenly. Fetch water from that well and measure the concentration of the dye in that water. All I now need to do is, since all of my dye is now in that well, the concentration times the volume in the bottle is equal to the concentration times the volume in the well. So if I know the concentration in the well, and I know the amount I had outside, then I just need to divide the amount by the concentration in the well, and I get the volume of water in the well. Okay, so the same principles, I'm using oxygen to diffuse, to displace nitrogen. I will collect all of the expired air, and then I will do the math. And I try to explain it here, but I don't know if this is good. Patient breathes oxygen through one-way valve. Oxygen dilutes the 80% nitrogen in the alveolar air to a lower concentration. Nitrogen is washed out of the lung into the expired air container over several minutes and completely washed out of the lung in about 6 to 7 minutes. The functional residual capacity can be calculated from the known volume of air and the lower concentration of nitrogen in the expired container. That is what that is. It's simple. Yeah.
So 6 or 7 minutes, the minimum amount of time that the patient has to breathe?
We'll have to breathe the oxygen to make sure you completely wash out the. So what I want you to remember, are you all clear with this?
Why are we using this? What is this for? Why do we use this method? Like, what is it for?
Because we want to figure out what is the functional residual capacity of the patient. That's why I told you, when you're breathing at a tidal, in your tidal space, the air you breathe is equilibrating with the air left in your lungs. Because in the tidal space, you have respiratory reserve volume and you have residual volume. There is no way to directly measure those volumes. So in order to measure those volumes, we expose people to this kind of technique, breathe oxygen. What we really want to know is the functional residual capacity. We have no way of measuring it directly. So we now give somebody, the patient, oxygen, and then allow them to wash out their nitrogen, and we use the nitrogen changes in concentration to estimate the functional residual capacity. It's just a method. You don't really need to understand the process, but you must know the name of it. Fowler's method, right? The same principle is what you use for helium. The same thing. You take the patient, you give them helium in the air, they breathe. After equilibration, you know the amount of helium they got, and you know the new concentration of the helium. Then the volume you're looking for is that V2, the functional residual capacity, right?
So that's the same thing, just with helium.
The same principle. You get helium, a specific volume of helium with a particular concentration. So that is the amount of helium. When the patient breathes the helium gas and the helium is now in equilibrium, because the helium is now in the lung, it is being distributed in a larger volume. And the difference in volume is actually the functional residual capacity. So since we know that the amount we gave is what is in the lung, we do our mathematics and we can figure out what V2 is, because V2 now equals the volume in the lung, which is the functional residual capacity. Are you with me? Mm-hmm. Good. So it's the same technique. Just remember that you know the quantity or the amount, and there is a specific space you don't know the volume of. But if you can introduce that quantity, the amount you know the concentration, you know the volume, into that space, and you are able to measure the concentration of that substance in that space, then you can figure out what the volume of that space is. The reason this is important is because this is the only technique we have to estimate, to estimate functional residual capacity, right? Are you with me?
Yeah.
Okay, let me tell you why functional residual capacity is what we estimate. Because think about it, if you can figure out what the functional residual capacity is in a patient, all you need to do to figure out what the residual volume is to tell them to breathe out maximally. And if you get what they can breathe out maximally, that is the expiratory reserve volume. If you subtract that expiratory reserve volume from the functional residual capacity, that gives you the amount of residual volume, right? And all you need to do now is tell them, take a deep breath to the maximum, and once they take a deep breath to the maximum, you now have the inspiratory capacity. When you add that inspiratory capacity to the functional residual volume, you get your vital capacity, right? And if you now add that vital capacity to residual volume, you get total lung capacity. This is why this is the only one we can measure, but from it we can deduce everything else. You got it? Excellent. So when there is bleb when there is bleb and bullae, those volume things don't work because you're going to underestimate the space, right? So we use body plethysmography. Body plethysmography is a crazy technique. You put a patient in a chamber, right? And he has a mouthpiece, right? And then you tell the patient, keep taking a deep breath. And after a while, you shut up the mouthpiece and tell the patient to inspire. When the patient inspires, the lung will expand. And because of the expansion of the lung, the chest space will expand. And technically speaking, the volume of the chamber will decrease by the amount by which the chest expanded, right? And you can now use the pressure changes and the volume changes to compute what the patient's volume was. It's very simple. It's based on Dalton's law, right? You remember Dalton's law? The pressure exerted by gas is indirectly proportional to the volume, yada, 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 right? So you have like V1 over V2 equals V2 over V2, right? And that constant there, forget about that constant. So basically you put the patient in the chamber. You know the volume of the chamber? What you don't know, really, is the patient's volume when they take a deep breath. You don't know that. But you have access to the pressures. Because when your patient is taking a deep breath against a short valve, the pressure in their mouth is exactly the same pressure in the alveoli, because it's one continuous cavity, right? So you know the pressure in their mouth, what it was before and after. You know what the volume of the chamber is. You do the math. And from the expansion in inspiration and the pressure changes associated with it in the chamber, you can compute by what amount the patient's chest expanded, okay? Which is a reflection of the lung volume of some sort, right? So this is a technique. Like I said to you, if you can understand it, understand it. If you need help, see me. But it's pretty, to me, it looks straightforward. I mean, the story I'm telling here in words is what is written here, is what is put here. So the patient is sitting in the chamber. It's like a telephone booth. but very sophisticated chamber that can track volume changes and pressure changes, right? And you have the patient breathe. And in order for this to work, the assumption is that when no air is flowing, because the valve is shut, the mouth pressure accurately reflects the alveolar pressure, right? So you know what the pressure is in the alveoli. You don't know what the volume is, but you know what the pressure is. But in the chamber, you know what the pressure is and you know what the volume is. So because you know what the pressure is and the volume is in the chamber, and you know what the pressure is in the alveoli, it's easy to compute what the volume is in the alveoli. Straightforward, right? Talk to me.
Yes.
Okay. All right. Finally, nobody believed that you could actually measure lung volume from chest X-ray. But in 1981, these guys, J. Block and his group, they published this article that they could do it. It turns out it's a special technique. Nobody really uses it, but it exists. Okay? So I'm just telling you, they reported this, and this was exactly what they said. I gave you the reference, you can pull it up. It's in critical care. It was in 1981. So the fourth method for assessing lung volume is from plain chest X-ray. And that technique is called planimetry. And they tell the patient to breathe out and breathe in, and they can figure out the difference from the chest X-ray when the patient takes a deep breath and when the patient is exhaling fully, and they can compute the volume. They say they can. I'm not a radiologist. Maybe we'll talk to Hansen. Maybe he can help us figure it out. But that is it. Okay? Again, I'm repeating myself here, and everything here I already told you. The first lung volume usually determined is the functional residual volume or capacity because it is readily reproducible and independent of patient compliance. Right? All you have to do is breathe. Exhalation from functional residual capacity gives the expiratory reserve volume. Right? Residual volume can be deduced by subtracting expiratory reserve volume from functional residual capacity. Vital capacity can be deduced by adding instrument capacity to functional residual capacity. And if you add residual volume to vital capacity, you get the lung volume. Okay? I told you that earlier. Okay, good. Why do we even bother with all this crap? Why are we doing all this? You guys want a break?
Yeah.
You never say no to breaks. What's up with that? Go. 5 minutes. Yeah.
So I don't see the relationship between like physiologic evolution and dead space.
And that's the same thing.
Oh, it's the same thing.
Physiologic means that the end result is the same.
Okay.
Because when you have dead space ventilation, blood will go to that space and it will not get oxygenated. But that same blood will now mix with well-oxygenated blood in the left atrium. Okay, so ultimately it's like the right side is less oxygenated blood is mixing with well-oxygenated blood. So functionally it's a physiologic shunt. Exactly. But when you have an anatomic shunt is when the alveoli is completely collapsed and blood travels directly from the pulmonary artery straight to the pulmonary veins without getting exposed to air at all. So they are both, it's like different level of severity of the same condition.
Okay.
Yeah.
I got it.
Yeah.
Thank you.
Okay.
For that last one, the volume and the pressure, was it the volume of inspiration only?
Yes, because you have the patient take a deep breath, and when they take that breath, their chest wall moves and expands. That expansion of their chest wall is picked up by the chamber, and the volume of the chamber decreases by exactly the same amount.
Okay.
So the thinking is that when that patient is taking that deep breath, the volume that is displaced is actually the functional residual capacity of the patient.
The functional residual. So they're saying it's equivalent.
It's equivalent,
Okay.
and then they can now, because the chamber gives you what the pressure is in it before the breath, it gives you what the volume is in that chamber. And when the patient now take a deep breath and displaces air, you know how it is sometimes, like one door is, it will change the volume and the pressure in the chamber. And we assume that the pressure in the patient's mouth is the same as in the alveoli. So that means we have the pressure in the alveoli, but we don't know what the volume is. But since we have the pressure and the volume in the chamber, and we have the pressure in the alveoli, we can figure out what the volume of the alveoli is.
But that's only for the alveoli? Or?
Because all the air in the lung is in the alveoli, right?
Right. Oh, yeah.
Remember sometimes how your bedroom door will be a little bit open, and somebody comes in your house and your bedroom door will slam. It's the same principle. Somebody opening the door pushes air in the house, and the air closes all the doors. Right? Or sometimes you open one door and you hear one door closing. The same pressure volume changes. Exactly. That's how the chromatography works.
I just have a quick question between the techniques, helium, the nitrogen washout. There's no difference.
There's no difference. It's just substance. One is nitrogen, the other is helium.
So as clinically, you can choose either.
Either of them, yes. Thank you. You saw my email too?
Yes. I know.
That's like later on.
Oh yeah,
Yeah, Dr. Matthews, you said that here, vital capacity can be deducted by adding this and this, but that will give you the total lung capacity.
Say it again.
Inspiratory capacity plus...
Yeah, inspiratory capacity is from end of tidal volume expiration to maximum lung volume, right?
Yeah.
So what I'm saying is, vital capacity can be deduced by adding inspiratory capacity to functional residue. So
that would give you
total. Sorry. No wait. No, not total. It will give you. Oh wait, yes, you're right. That what I was saying is vital capacity can be deduced by adding vital capacity. You add inspiratory capacity.
It should be to expiratory reserve volume.
Yes.
Like you
Thank
know.
you. I need to fix that.
Really quick.
When you were talking about getting the residual volume, I know you said if you get residual volumes, you can get all the other volumes.
No, functional residual capacity.
Okay. So wouldn't you also want to know what the residual volume is to see how easy it is for the lung to place?
The way you do it is you don't do it directly. There's no way to measure residual volume directly. So you measure the functional residual capacity, and then you measure the expiratory reserve volume. You subtract expiratory reserve volume from functional residual capacity, and that gives you residual volume.
Right. So, but isn't the purpose also knowing the residual volume to see how much
You can't measure.
You're not really knowing what's in there. You're just knowing it based off the volume.
Exactly.
Okay.
It's not possible to measure it directly.
What I was thinking is when you talk about last class that when something's partially inflated, it's easier to inflate.
Yes.
But when it's not partially inflated, it's harder to inflate.
Yes.
So I was thinking that if we knew the residual volume, and if someone had low residual or high residual, we don't know. Right. Okay. I get it.
All right. Let's go.
You think I'm lying? Why am I lying? Just admit it.
There is a mistake. I always love when somebody can pick a mistake in my slide. Usually I give a stethoscope. So for whoever can find an error in my slide. And somebody just did. So, Tolu, I owe you a stethoscope. So you see, there is a mistake here. Unfortunately, I don't have the slide. Vital capacity can be deduced by adding inspiratory capacity, not to functional residual capacity, but to expiratory reserve volume. If you look in the diagram for the lung volumes, you will see that if you add vital capacity, if you add an inspiratory capacity to functional residual capacity, what you actually get is total lung volume, right? But if you add inspiratory capacity to expiratory reserve volume, that gives you the vital capacity. So change this to expiratory reserve volume, ERV, please. All right. So I was telling you that why are we doing all these volumes? Because these volumes are very helpful. They are very helpful. My next slide makes it very clear to you. So, are you with me? You corrected that? Good. So look, this is a young man. This is his total lung capacity. This is his residual volume. This is his expiratory reserve volume. This is his inspiratory capacity. Okay? This is an elderly man. You notice that your lung capacity does not increase with age, right? But definitely your expiratory reserve volume diminishes and your residual volume increases, right, with age. Your expiratory capacity also shrinks because with age, your bones and joints, they become arthritic. They're not able to expand like you used to be able to expand when you're young, right? So the old people are not able to exhale maximally as young people. So they have limited capacity with expiratory reserve volume and their residual volume increases. Okay? Pay attention to that. Because this is why we measure this volume. They get distorted by different pathologies. When you have obstruction, whether COPD or emphysema, you distend your lung. So you see lung capacity is increasing, right? With emphysema, early emphysema, call this bronchitis, whatever. COPD. One thing it does, it increases your lung volume, right? But it does it throughout, including the residual volume. Because remember, in airway obstruction, the problem is the air is getting trapped. So the increase in the lung volume in airway obstruction is usually due to increasing residual volume. So when you do volume analysis in COPD patients, you see this pattern of increased lung volume with increase in residual volume, right? When somebody has pulmonary fibrosis, where the lungs are shrunken down, you see what happens? The lung volume is less. Remember the flow volume loop is shrunken, right? On the flow, on this volume and capacity analysis, you see the same thing. Residual volume also is decreased, right? Everything is decreased proportionally in pulmonary fibrosis, right? But look at what happens in neuromuscular disease. In neuromuscular disease like Duchenne dystrophy, myasthenia gravis, see what happens? Lung volume is decreased, but look at residual volume. It's almost double because the muscles are weak. Residual volume is increased. Even though the total volume is shrinking, residual volume is increased. And look at what happened with severe obesity. That is an example of anything on the chest wall. That could be kyphosis, it could be a cicatricial burn scar. You know when you get burned around the chest and you form scar tissue that constrict your chest? Yeah. You see what happens? Total lung volume is decreased, but residual volume is preserved because the lungs are normal. The underlying lung is normal. Residual volume is normal. Whereas in pulmonary fibrosis, the underlying lung is shrunken, residual volume is decreased. Whereas in neuromuscular disease, residual volume is increased. So, I'm summarizing it over here by saying aging reduces chest wall compliance and causes an increase in residual volume, but the total lung capacity remains normal, right? And I said obstructive lung disease, they cause hyperinflation and an increase in total lung capacity that exceeds 150% in COPD patient with severe emphysema. And here is a complicated sentence, but I think you can understand it now. Restrictive lung diseases, they exhibit reduced total lung capacity with a relative preservation of the residual volume in chest wall disorders like obesity, because the underlying lung is normal, with a reduced residual volume in pulmonary parenchymal disease as in fibrosis, and increased residual volume in neuromuscular disease. So even though total lung capacity is reduced, you can use the residual volume to differentiate between chest wall disorder, neuromuscular disorder, and pulmonary fibrosis. Okay? So that's how you analyze lung volume. That's why we do it, because it helps us figure out what the heck is going on with this patient. Okay? Everybody clear with me? Good.
I have a quick question. So for emphysema, does it affect the IC at all?
Oh yeah, it increases. You see, all obstructive airway diseases, inspiratory capacity is preserved. Because remember, inspiratory capacity is a reflection of your chest wall compliance and the muscles, right? What is the total lung volume you get in COPD is due to increase in residual volume.
Just the residual.
Yeah, residual volume. Okay. Anybody else? Excellent. You've seen this before, right? Spirometry. So spirometry, the patient sits down and you tell them, take a deep breath, blow on as fast as you can, and then you get a tracing. But what we're really looking for, we are using this to assess, remember, resistance and obstruction, right? What we are looking for is what is called the first expiratory volume in the first second. Okay? So here is the patient sitting there with the stuff. They clip their nose because they want them to breathe only through the mouth. And then the patient is taking a gentle breath. And they say, take a deep breath. So from that deep breath, you can measure their inspiratory capacity, right? And I say, okay, now I want you to get rid of that breath as fast as you can. And then you see what they can get rid of in the first second. That volume of air that they get rid of in the first second is called the FEV1. Okay? First expiratory volume 1 is the maximum amount of air the patient can get out from inspiratory capacity in the first second. It's a reflection of the obstruction of the airway. Okay? And then you now tell them, keep going until they can get all the air out and they can't go anymore. That is the measure of your first vital capacity. So the patient is sitting like that. The step begin by saying, okay, take gentle in and out breath. They're operating in the arterial space over here. You just stop writing and look up. You see, they're operating in the arterial space, in and out. And then the technician will tell them, now take a maximum deep breath. Then they go, boom, they get here. That is their inspiratory capacity, right? And then from that, they're instructed, push the air out the fastest you can. Then you measure the amount of air they can put out in the first second. That amount of air, the volume of air they can get rid of in the first second is called FEV1, first expiratory volume 1. And then you tell them, keep going until they can't get rid of any more air. Then that gives you the measure of their first vital capacity, right? So this is how the test is done. This is what the tracing looks like, right? Remember this tracing? Right? Only more, I'm telling you a little bit more information here. They do, respiratory people, pulmonologists and respiratory physiologists, they do crazy stuff with this loop. Do you know that they have machines that can analyze the slope at different levels across this expiratory loop, and they can use the slope to tell you what the level of obstruction is, whether it's in the central airway, it's in the mid airway, or it's in the terminal airway. Because some people normal beginning and then they will flat out toward the end. Some people have slow beginning and then they will become normal. So the shape of this portion of the curve actually depends on at what level is the obstruction, right? If somebody has been intubated so many times and they have tracheal stenosis, it's an obstructive airway disease, but that obstruction will be early on in expiration. So the first part, this FE, this is this first expiratory flow in the first 25% of the flow will be the most affected. But if somebody has COPD, where the damage is more in the secondary and primary bronchioles, it might be in the FEF 50%, right? That is mid-range, right? If it's in the terminal airway, like in bronchiolitis, the obstruction will be more in the FEF 75%. So these numbers are the percent across this respiratory curve, okay? So we send people for spirometry, we want this curve. As you can see, this is a very subjective test. Patient can screw you up big time. So what you do is, in order for you to use the number, you have to have the patient do it 3 times, and you cannot have variation more than 0.2 liters. If you can get your patient to give you 3 readings, and the difference between the 3 readings is less than 0.2 liters, you have a good patient who can follow instructions, and then you can now rely on the number. The values vary with age, gender, race, and height, and weight, and position. So generally we talked about it in terms of percentages. Normal is 100%. That is compared to age and sex for that particular patient. So we have normal values for ages and genders. So we compare the patient's value to those standards. When the patient's value is in agreement with those standards, we say it's 100%. So normal is usually 80 to 120%, 100 plus or minus 20. Okay? You got it? Excellent. Oh, come on. So, this is a complicated chart, but it's really not. Let me tell you how to look at it. You know what FEV1 is, right? And you know what FVC is, right? Good. What I want you to know is, in reality, a normal FVC and FEV1, they are usually between 80 and 120%. I just told you that, right? In practical terms, FVC is really an index of restriction. So if you have a restrictive lung disease, FVC will pick it up. So if somebody has normal FEV1 and the only abnormality is FVC that is reduced, you can say that is a restrictive lung disease. FEV1 is an index of obstruction. Okay? So if everything else is normal but FEV1 is decreased, the patient has obstructive lung disease. Unfortunately, nobody has pure obstruction or pure restriction. These two conditions, they overlap. So most of the time, both FEV1 and FVC will be decreased. Now you now depend on the ratio to make a decision. When both of them are decreased, then we now depend on ratio. You now use the FEV1 to FVC ratio. If it is less than 0.7, that is obstruction. If it's more than 0.7, that is normal, but it's also restriction. You got it? Okay, that is important. So this right here is the gist. This table, whatever this thing is, this chart here is now taking you more into the analysis. How do you think about it by the bedside? Okay, this is the basic gist, remember that, okay? So it says, okay, when you are looking at spirometry result, you look at the functional, the first vital capacity, the first expiratory FEV1, and you look at the ratio. If everything is normal, your patient is normal, right? Now, if FVC is normal or decreased, or FEV1 is decreased, or the absolute ratio is less than 0.7, your patient has obstruction. Now, when your patient has obstruction, you want to find out, is this a chronic obstruction or is this an intermittent obstruction? So you do what is called a bronchodilator challenge test. So you give the patient an albuterol or something, and now you repeat the test. If the obstruction relieves, if FEV1 increases by 12% or by more than 200 mil, right? That means your patient has a reversible airway obstruction, like asthma. But if you do not get a response to that bronchodilator challenge test, that patient has COPD. Sometimes you see patients, they have history of asthma, and then they are smoking. And then they come and say they have shortness of breath. I'm like, what in the world do you want me to do? You know you have asthma. You keep smoking. What am I supposed to? I don't know what to treat here. You know, so generally I send them to go do bronchodilator challenge test. I want to know, what am I treating? Is it COPD or is it asthma? Because the guidelines are different. You know. So you see, this is what this is telling you here. Now, if you have the ratio more than 0.7, which is the amount normal, but in this case your patient is asymptomatic. If your patient is symptomatic and you have less than 0.7, that is a restrictive lung disease. That is the end of it. And really, the only other thing you can do is to say, okay, how bad is the restriction? How good is the lung still able to allow oxygen to go through? So you send the patient for DLCO, right? And then, remember, this can also be as a result of ventilatory impairment. Okay? Not just, remember, restriction, when you have restrictive lung disease, it will present exactly the same way as morbid obesity, right? Because the only difference is that in morbid obesity, the residual volume is preserved, whereas in restriction, residual volume is constricted, right? So in order to rule out any ventilatory component, you do what is called maximum voluntary ventilation. Okay, so somebody with restrictive disease, you want to rule out ventilatory impairment. Okay, remember, restriction means the lung volume is shrunken. You need to decide, is it because the patient cannot take the breath, or is it because the lung are destroyed and shrunken? So even though the patient can take the breath, they are not able to distend the lungs. In order to tell those two things apart, you do what is called maximum voluntary ventilation, and basically you have the patient to breathe as fast as they can, deep and fast, for about 12 seconds, and then you extrapolate that to 60 seconds for a minute. And under normal circumstances, the maximum voluntary ventilation is about 40 times FEV1. That is normal. If it is less than that, your patient has ventilatory impairment. You're not going to do this. The pulmonologist will do it, but they will send you a result that maximum voluntary ventilation is 60. FEV1 is this. You have to compute it yourself and say, there is ventilatory impairment or there isn't ventilatory impairment. Okay? The reason this is important is sometimes you see patients with glucose who are also overweight, and they come with respiratory failure, and you do your spirometry and you see, oh, restrictive lung disease. Now you don't know, is it restriction because of interstitial lung disease from glucose, or is it restriction from the massive weight on the chest? Then you have to now send them for maximum voluntary ventilation. If it is due to the weight, the maximum voluntary ventilation will be reduced. But if it's due to the lungs, maximum voluntary ventilation will be longer. Okay, you got that? Excellent. So I put some information here for you to know that how do you compute this ratio? Is an absolute ratio. So you really divide the numbers in liters by themselves. Okay?
Dr. Mark, for the maximum voluntary ventilation, am I just like adding those like 12, like as many as they can?
Yeah, you do. You have the patient breathe deep and fast as they can for 12 seconds, and then you count it, and then you multiply for 12 seconds. Then you multiply it by whatever you need to do. By what? By 5. To get up to 60 minutes. And then the normal is 40 times FEV1. Right? Okay. That's what it normal is. Okay? You got it? Moving on. So diffusion capacity, how is it measured? This is another one of those, but it's a little bit different. So when you want to measure diffusion capacity, you tell the patient to take a single breath. And in that air that you're giving them, there is carbon monoxide. Okay? Small level. So single breath carbon monoxide diffusion is the most common method for determining diffusion capacity of the lungs, and that's why it's called DLCO. So the patient blows out all the air in their lungs, leaving only the residual volume. You now tell them to inhale maximally a mixture of air that contains 0.3% carbon monoxide plus a tracer gas. Usually we use helium or methane. And they take it in as rapidly as they can, and they hold their breath for 10 seconds. The reason for holding their breath for 10 seconds is for equilibrium to take place. When the equilibrium takes place, you then tell them to breathe out. When they now breathe out, you now measure the gas again. Since you know that helium is inert, it doesn't go into the body, it stays in, right? You now know what has happened to helium. The same thing should have happened to carbon monoxide. The difference between the amount of carbon monoxide in the exhaled air is what went into the patient. That's how you determine the diffusion. You got that? So the patient exhale maximally. You now give them a mixture of air that contains carbon monoxide and helium. Helium is inert. It doesn't go in, it doesn't diffuse. But carbon monoxide will diffuse because it's very porous. Right? Now, we can take in both gases, hold it for 10 seconds, equilibrium takes place. You now exhale. You now measure the amount of helium and carbon monoxide. It should be the same as it was when it went in. The helium will tell you, yes, the test was good because the helium concentration will be the same. But carbon monoxide will not be. The difference is what went in. So that's how you determine carbon monoxide diffusion test. Now, it is also known as the transfer factor of lung for carbon monoxide, TLCO. It is expressed in mils per minute per millimeters of mercury. The average again is 100%. I need you to know that the determinants of DLCO are surface area of the lung available for gas exchange, the rate of carbon monoxide uptake by alveolar capillary blood, because if you have bullae and bleb and stuff like that, there isn't enough surface area. It will compromise that capacity. If blood is not flowing fast enough, the uptake will be slow, even though the membrane is intact. That is why when they give you DLCO, they always give you DLCO corrected for hemoglobin. Okay? So they will correct it for hemoglobin to tell you, okay, because it could be low, not because patient is sick, but because they are anemic. Right? Good. So there are some things you must know. This table looks complicated, but it's really easy. The people that did it are not smart people. Because if you look at it, let's look at this table. This table would be a lot easier to understand if they put morning against evening. Right? Your DLCO is higher in the morning. Because in the morning you're fresh, your volume is okay. In the evening you're coming back from work, you're tired. Blood volume, you're not going to be able to do much, right? In the evening. So you put morning, increase DLCO. Evening, it should be side by side so you could compare it easily, right? See, polycythemia will increase DLCO. Anemia will decrease it. They should have been side by side, right? Mueller maneuver will increase DLCO, or Valsalva will decrease it. They put that side by side, right? Supine position will increase it, but standing will decrease it because of differences in blood flow. Everything makes sense. Just take a look at it. The only thing that you need to think about a little bit more is obesity. Right? Obesity increases DLCO. Why? Why would obesity decrease DLCO? because it interferes with the ability to inhale the carbon monoxide. So the carbon monoxide, it's not that the carbon monoxide is not able to diffuse, but the amount of carbon monoxide the patient can actually take in as a result of obesity is less. So let me give you a mathematical illustration. Say the patient, you give the patient can inhale 100 molecules of carbon monoxide because they are able to inhale, and 10 of that carbon monoxide diffuse across because they are able to take in 100. What will the DLCO be? About 10%, right? Now, say the patient is obese, and because they are obese, they are not able to take in as much air, but they are able to take in 50. And 10 will still diffuse across. You see, the DLCO will be inflated. Not because the patient is efficient, but because the denominator is narrow, right? That is how obesity can cause an increase in DLCO. Okay, everything else is the same. Pay attention. Asthma and COPD, they cause an increase in DLCO, but emphysema causes a decrease in DLCO. Okay? So pay attention to this table because I tested, right? And I just needed to know that these are the things that increase it, these are the things that decrease it. Yes. I'm saying that I'm trying to give you a plausible explanation for the increase in DLCO in obese patients. Because remember that if restrictive lung diseases, interstitial lung disease decreases it, you would expect obesity to decrease it. Because when you do volume analysis, lung volume is decreased with chest volume instead of obesities. So I'm saying that let's assume that a normal person, lean person, is able to inhale, to generate negative pressure to allow, say, 100 molecules of carbon monoxide into the alveolar space. And the alveolar capillary membrane is efficient to allow only 10 of these molecules to go through. The DLCO will be 10%. But say an obese patient who is not able to take a deep breath is only able to take in 50. But the alveolar capillary membrane is still efficient, allows 10. Now, this is 10% because 10 over 100, right? This is now 10 over 50. This looks like double, right? It makes the DLCO looks better, but it's not because the membrane is more efficient, but because the patient is able to take in less air. It's not able to take in the amount of air it needs to take in. All right, are we good? Excellent, so let's have some fun, we have some time. Why do you do pulmonary function test? I just told you we don't do it all the time. But there are times you really should do it. If you're screening a high-risk patient, heavy smoker, or somebody who works in a place where they are exposed to hazardous material and they want to sue, the court will need some evidence, right? So you can do it then. If somebody has respiratory symptoms like stridor, cough, dyspnea, and you can't explain it, you do that. If you think somebody has asthma and you give them bronchodilators and they are not responding to bronchodilators, you want to do test to figure out what the heck is going on, right? Somebody needs to have a pneumonectomy, then they can't have the lungs. You need to make sure the patient can afford to lose that lung. So you have to assess the capacity of the lungs and see, can they lose this much if you cut this? Can they do you have to do a whole lobe, a sub-segment, lobectomy? What amount of the lung can they afford to lose? You know? And you as primary care doctors and primary care clinicians, you really need to be pushing for this because surgeons don't think. They just want to cut. Right? And you have to pull the brakes all the time. Now wait, let me just send this patient for lung volume assessment first. Because the good thing is that nobody, the anesthesiologist will not put any patient to sleep that you have not cleared for surgery as a primary care person. So you have that power in practice. You know, we need to do this before you can do this. So, preoperative risk assessment, and then somebody wants to get Social Security disability. Social Security disability has specific requirements. Your DLC has to be less than 30 in order for you to be considered disabled from the lung capacity, right? So these are the indications for it. You want to monitor disease activity. I gave you an example of somebody with lupus who might be smoking. You keep telling them stop smoking, but they keep smoking because they're under stress. But all you can now do is monitor them, right? And then when somebody has lung disease and you want to see how well they will do, you can also do this pulmonary function test to kind of see how well will you do with your disease, given your progression. Your PFT was here 2 years ago. This is where it is now. Where would it be in the next 2 years? Maybe you need to start doing some estate planning. You cannot do it in respiratory distress. You can't do it in acute situation. Patient, you don't have time for that. That is why I put TE under the management of respiratory failure. You have no time to evaluate. You need to treat the patient first. So in acute situations, you cannot do that. Demented patient cannot follow instruction. So take a deep breath. Can you hear me? Yes. Take a deep breath. What did you say? That is what you get with dementia. You can't get them to follow instruction. Somebody has dementia, or somebody's blood pressure is high, in hypertensive emergency. You don't want to aggravate them, having them hold their breath for 10 seconds. They will pop a vessel in their brain. You end up with a stroke right there. So you won't do that. Somebody has angina and they have chest pain. You better figure out what the heck is going on before you put them in anything to test anything, because they could have a complication of a heart attack and you'll be liable for whatever happened. So a patient has to be really stable, okay? Contagious infection, TB. You're not sure everybody is free of TB. You put them on your spirometry. The next patient is at risk, because there's no way you can clean the inside of the machine, right? So these are the contraindications for this thing, right? And your patient has cold. They are breathing through their mouth. Do you really want to clip their nose and put something in their mouth when somebody has a runny nose? That's all messy, right? You don't want to do that. So those are contraindications of pulmonary function test. So let's do some, any questions here? You're all cool, right? All right, so let's start with Kara. I have latched onto you.
You have.
You're not getting Which of the following arterial blood gas result or room air is indicative of a type 1 respiratory failure?
So that's hypoxia, so it would be the D, right?
D. For real?
No?
Did you say D as in David?
It wasn't going to 7.4 because that's hypercapnia, right?
No, you only need two numbers. Look at the PO2 and look at the PCO2. That's all you need. Which one here? D?
No.
So just
Oh, I see. You're having difficulty with what the normal values are.
Yeah.
There's no
Okay.
philosophies.
Okay. Then I'll help you with that. PO2 is 60, should be above 60, and PCO2 should be less than 40. Okay. So which one is it?
So you said PO2 should be above 60?
Yes, and PCO2 should be less than 40. It's A, right? Okay, yeah, it's A. Okay. All right, Mia.
Isn't it B?
Wait, can we go back?
PO2 should be
PO2 should be normal.
Less than 60, right?
Wait, why is it?
But you said type 1. Type
B?
1 CO2.
Yes, type 1 CO2 should be normal. Not, it shouldn't be high. It can be low. And in fact, most of the time it's low because hypoxic patient hyperventilate. Remember, what I said is type 1 is hypoxic, type 2 is hypoxic and hypercapnic. So it cannot be B because CO2 is high. B, CO2 is high. So it cannot be B. The answer is A, right? It's got to be, type 1 has to be hypoxia. CO2 can be low or normal. What it cannot be is to be high.
Okay.
You got it? That is why it was called hypercapnic.
You said 60 and 40, right?
60 for PO2 should always be above 60. PCO2 is 40 or less.
Okay.
Right.
So I
Okay.
get to be E. E is the
E?
25.2 and 30 for CO2.
But it's still PO2 is normal.
Oh,
It's
okay,
90.
That's right. So
Right?
it's hypoxic, yeah.
Yeah. Type 1 is hypoxia. You must have hypoxia and normal or low CO2. Okay? All right. And then, you're next. Oh, please. Which of the following is a plausible mechanism for a low PO2 at a high altitude? A plausible mechanism for a low PO2 at a high altitude. D as in David? David, right?
Yeah.
I'm going to hypoxia. Okay, that's great. Alex. Which of the following statements is accurate about functional residual capacity? It is the sum of expiratory reserve volume and residual volume. It is the difference of total lung capacity and inspiratory capacity. It is directly determined in pulmonary function test. All of the above. None of the above. Good luck with that. All of the above. Good. All right. Everybody agree with that? Okay. Christian, which of the following is associated with pulmonary embolism? Everybody agrees B? No, they don't agree with you. Think again. Pulmonary embolism. Eh? Exactly, it's D, some of the above. It's a cause of type 1 respiratory failure. Remember, it will give you arterial hypoxia. It's a type 1 respiratory failure. And when there is widely A gradient, it can only be diffusion capacity or BQ mismatch. Right? Remember that. So it's all of the above. Right? It's a type 1 respiratory failure with wide A gradient. And it will respond to oxygen. Right? Okay. Bradley, what? You okay?
Yeah.
All right, Bradley. Which of the following types of hypoxia is associated with cyanide poisoning? Histotoxic. Thank you. David, which of the following parameters can be used to tell hypoventilation apart from airway obstruction in a patient with type 2 respiratory failure?
The A ingredient?
A gradient? Yes, A gradient. But PF ratio is also useful. Okay? PF ratio is also useful. You know what PF ratio is, right? Did we talk about it?
What's what?
PF ratio. Yeah, I know. I should have talked about it. It's in there slide. It's in there somewhere. PF ratio is very helpful when you have BQ mismatch. You know, remember anatomic shunt and physiologic shunt? I told you is the same condition of different severity. When somebody has ARDS, that is the anatomic shunt, their PF ratio is usually less than 300. And PF ratio is basically the, bless you, is the PaO2 divided by FiO2. That's what it's called, PF ratio. So you say PaO2 is say 60 on 60% of oxygen, 0.6. You divide that like that. If that number, that quotient is less than 300, that's a bad thing. If the patient has type 1 respiratory failure with a PF ratio less than 300, that is ARDS. If the patient has a type 2 respiratory failure with an abnormal PF ratio, that is, with an abnormal PF ratio, that is COPD, not hyperventilation. Okay? Remember, in hyperventilation, AA gradient is normal, PF ratio is also normal, right? But in obstruction. AA gradient is wide. PF ratio is also low. Okay, are you with me? I didn't talk about it. It's there on the slide. I just didn't talk about it. Right. Let me repeat that. You use PF ratio to determine the severity of the type 1 shock. So whether it's anatomic or physiologic, if you have a type 1 respiratory failure and you're sure it's due to VQ mismatch, right? You compute the PF ratio. If PF ratio is less than 300, that is ARDS, right? But if it was a type 2 respiratory failure and PF ratio is low, that is usually obstruction, not hyperventilation. So you can actually use both AA gradient and PF ratio to tell, right, hyperventilation from obstruction in a type 2 respiratory failure. Okay, just one other thing that can help you differentiate that. Okay, moving on. Stephanie, what is the estimated AA gradient in a 40-year-old construction worker?
It's 40 times 4.
40 divided by 4 plus 4. What is that?
14.
14. Good. Maureen, ventilation of alveoli that are not perfused is an example of which of the following anomaly? What? If an alveoli is ventilated but is not perfused, what is that? B. You say B? Yeah. Dead space ventilation. Okay? Stanley, which of the following is the mechanism for respiratory failure in a patient with a tense ascites and diaphragmatic splinting? Diaphragmatic splinting is when the diaphragm cannot descend. Okay. So what is the mechanism?
What did we see?
The diaphragm cannot descend. So is that obstruction?
No, it's not.
Is it hypoventilation? Yeah, think about it. I mean, you want the hypoventilation means whatever needs to take place to allow air to go in is not happening, right? It could be because the patient is not breathing, initiating it in the first place, because he can't get the information, the brain cannot get the information down to the muscles. It could be nervous, or it could be the muscles are weak, they can't respond. Or it could be that the muscles can respond, but there are things in the way, like babies, ascites, all that stuff. So that is definitely a perfect example of hyperventilation. Okay? Yeah. Lenny, which of the following statement is accurate about vital capacity? It is the sum of inspiratory capacity and expiratory reserve volume. It is the difference of total lung capacity and residual volume. It is directly determined on spirometry. All of the above, none of the above. Huh?
Oh, difference of
Is it the sum of inspiratory capacity and expiratory reserve volume?
That was A.
Yes. Right? Is it the difference of total lung capacity and residual volume? Yes. Is it directly determined on spirometry? Yes. So it's all of the above. Right?
Let's make it happen.
It's all of the above. Are you confused about this?
Just clarification, forced vital capacity is the same as vital capacity, right? It's just
Yes. No. Yes. Forced vital capacity is when it is determined from spirometry. Right. Okay. When it is determined by adding stuff up by helium dilation, then it's vital capacity. Right. Okay. It's not always forced. The only time it is forced is when you determine it by its parametry. Good question. I should have clarified that. Wendy, which of the following conditions is not a cause of type 2 respiratory failure? In other words, which one is not hypoventilation and which one is not obstruction? That's what that is. Type 2. Which one is not hypoventilation or obstruction? Everybody to Wendy's rescue. What is it? D. Why? Because type 2 respiratory failure usually means hypoventilation or obstruction. Pneumonia doesn't cause hypoventilation. It doesn't cause obstruction. It's an alveolar filling disorder. It causes VQ mismatch. Right?
Yeah, think about it.
Alright, okay. Well, you got it now. Okay. Pulm. Which of the following is a clinical feature of respiratory distress?
Sorry about it.
Oh, all right. Okay.
That's the tricky one, still.
Chrissy. You brought it on yourself. What is the estimated FiO2 on 5 liters per minute of oxygen?
40.
Good. 40. Everybody agree, right? It's 40, right?
Yeah.
So it's 5 is 24 plus 16. Okay? Marianne, which of the following clinical features is not an indication for oxygen therapy? Not an indication for oxygen therapy.
Oh, that's, oh, sorry, that's the
Good. Tachypnea is not an indication for oxygen therapy. You could be tachypnea because you're crazy. You could be tachypnea because you're anxious. You could be tachypnea because you want me to give you knuckles. That is not an indication for oxygen therapy. It is respiratory distress that is tachypnea. That when tachypnea occurs within the context of respiratory distress, that is when it is an indication for that. Okay? All right. Bradley. Which of the following techniques is best for administering oxygen in excess of 5 liters per minute?
I know you want the ones that can get it, right? So face mask.
How would you give me oxygen if I need more than 5 liters per minute? I don't have COPD. I'm a regular guy.
Okay, then I need to see.
You will give me another very much. No, I didn't hear you.
Yeah.
It will help me better because I don't know why D and B always sound the same in my ears. So you have to tell me like C as in cat, then I'll know. Or you tell me what the answer is, face mask.
Face mask.
Right? So it will help. So fix it. Right. Which of the following conditions is not associated with an increase in diffusion capacity of the lung for carbon monoxide is not. So everything there will cause increase in DLCO2, except one condition.
That's my question.
That was your question? Yeah, of course. I'll help you. It's emphysema. It's emphysema. Right? Polycythemia will, because a lot of oxygen is going through. Bronchial asthma will, because it increases lung volume and the blood going through because of obstruction. Pulmonary hemorrhage, oh, this is frank blood in there. You will soak it up very quickly. Chronic bronchitis will do it because it increases lung volume. Emphysema will not, because it damages the alveolar wall. Alright? Yes.
Yeah, that was a question I want to ask you.
Yeah.
Actually, about the carbon monoxide, like why? I was wondering why you're doing that test. Are you trying to see if there's a lot of blood in the lungs?
Say it again?
For the carbon
monoxide diffusion test?
Using the carbon dioxide, right? Yeah. Carbon monoxide.
Yeah.
You're trying to see if there's like blood in the patient's lungs.
No, you're trying to see, you're trying to measure the integrity of the alveolar capillary membrane. In other words, is the membrane allowing oxygen to go through like it should? So you want to have a gas that will transcend that barrier fastest. So if the barrier is a problem, then DLCO will be reduced. It's a measure, it's an assessment of the integrity of the alveolar capillary membrane. It measures the ease with which a gas can travel from the alveolus into the capillaries.
By using carbon monoxide, using
fast
gas.
Exactly, using carbon monoxide, because carbon monoxide is it goes through chambers very quickly.
Even if that can't do it, oxygen definitely can't do it.
Exactly. That means carbon monoxide tells you, if carbon monoxide can go through it easily, it tells you the membrane is fine. Okay, good. Excellent. Terika, flow volume loops are useful for the evaluation of which of the following pulmonary characteristics? All of the above. Thank you. Right? What is the PF ratio in a patient with a PO2 of 60 on 5 liters per minute of oxygen? David?
So it's 60 divided by 40%, right?
Yes. Good. Good.
Let me do that now.
You know, the trick here is you never make the mistake of using that number wrong. You have to convert that number into FiO2 and then divide the PO2 by that FiO2 number. Okay? It's 24% for the first liter, and then 4. Yeah.
You add.
Huh?
150.
Yeah. So the FiO2 here is 24 plus 16, which is 40%. So the PF ratio is 60 divided by 0.4. And what is that?
150.
150. Good. Excellent. Okay. Kara, this is what you get. Pulse oximetry may be less.
Everybody else around me was asking.
I already talked to you. Pulse oximetry may be less reliable in all but which of the following conditions? When would you not rely on pulse? You rely on pulse oximetry in every one of these cases except in one case.
Okay, never mind.
Coma, exactly. Because in coma, the patient is still. No motion artifact, it should be fine. Right? Good. But in circulatory collapse, poor blood flow will give you problem. Peripheral edema, distance, African ancestry, the melanin is the problem. Black nail polish, interference. Coma is not one of those.
Can you explain? I don't understand why, if you're doing the pulse ox through a fingernail, why African ancestry would, my nails are the same as
No, because in your nail bed is melanin. Right? There's melanin in your skin. Right? Even though you're doing it through the nail bed, remember that the light is coming from below and above. Right? Yeah, so melanin. I hear you. Ross, this is the question that separates the boys from the men, okay? Alright, so this one is the mother of all the questions. And I want you to kind of give it a shot. It looks complicated, it's really very simple. Just pay attention, let's read it through. So here is a guy, 68-year-old smoker. The guy he went on vacation on Kilimanjaro. You know where that is?
Yeah.
Okay. He's on Kilimanjaro, he develops acute respiratory distress. The atmospheric pressure on Kilimanjaro is 660. Okay? And then they were able to do blood gas because he went with some of his friends who were RTs and everybody else. And they went there. So they have a blood gas. This is his blood gas. The question is, what is the most likely reason for this guy's problem on this mountain? Is he having COPD exacerbation? Has he exposed himself to cold because it's cooler behind you? Or is it just acute mountain sickness? Or is the guy just sick? How do you even begin to address this problem? So let's start. What is the first thing you want to do? I will help you. Looking at this case, you know this guy is this guy in respiratory failure? That's the first question. He's in respiratory distress for sure. I already told you that. But from the blood gas, is he in respiratory failure? PO2 is 50. It should be what? At least 60, right? PCO2 is 50. It should be below 40. So is this guy in respiratory failure? Yes? Okay, what type of respiratory failure? Is it type 1 or type 2?
Type 1.
Type 1? He has low oxygen, he has high CO2. How can you say type 1? Type 2 must have two problems: low oxygen, high CO2. So the guy has type 2, right? Now, what are the commonest causes of type 2 respiratory failure? Obstruction and hypoventilation, right? You can be presumptuous. Given the options here, right? There is no hypoventilation, right? There's no hypoventilation in this option, right? But there is COPD exacerbation. Based on those two information alone, you can come here and say, well, the only other thing that will cause type 2 respiratory failure is hypoventilation. COPD is the only thing here. COPD is the answer, right? And you pick it, that's COPD. But if you're smart, you won't take exams like that. Now, in this kind of case, you want to exclude everything else here, right? So let's now get to the real bidding. How do we exclude pneumonia? It's got to be an AA gradient, and it's going to be a type 1, right? So let's compute. What's the AA gradient here? Atmospheric pressure is 660, right? And the question says you should assume that water vapor is 47, right? So the first thing we'll do is to take 47 from 760. That gives us 613, right? Right? Right?
Yeah.
The guy is on room air on Kilimanjaro, so it's 21%, right? What is the answer here? 613 divided by 0.21. Oh no, times. I'm sorry. It's times. Yeah, 20. What? Is that the same thing? Well, tell me, what is 21% of 613?
128.
128. Okay. So this is the partial pressure of oxygen inside the alveoli, right? That's entering the alveoli. The one that is leaving is carbon dioxide over 0.8, right? So what is that one? This is 52?
40.
40?
Wait, are we dividing? Sorry.
50 divided by 0.8.
60.
What? 50 divided by 0.8, what is it?
62.5.
60?
2.5.
Okay, we say 62. All right. So that is 6. So the AA gradient is 66, right? What should it be in a guy that is 68? Is 68 divided by 4 plus 4. What is that? 1, 7, 21, right? It should be 21, but it's 66. So the A gradient is wide, right? So that means there is something wrong here. Either pneumonia A gradient is wide. It's inconsistent with COPD exacerbation, but we have to rule out pneumonia. So A gradient is wide. What is the PF ratio? PF ratio. Oh, please wait. Because we know that AA gradient is wide, it cannot be acute mountain sickness, right? Because acute mountain sickness means that lungs are normal. You will have hypoxia with normal AA gradient. That is what alveolar hypoxia is. Remember that?
Yes.
Yeah. If it is alveolar hypoxia, that means the lungs are fine. AA gradient will be normal. So the fact that AA gradient is wide here means that it is not acute mountain sickness, right? Good. Now, is it ARDS? Let's look at the PF ratio, right? So what is the P?
Can you just rule out ARDS because it's type 1?
No, because ARDS is the most severe form of type 1 respiratory failure. That is your anatomic shock. No. Type 1.
Yeah, but then we
Oh, yeah, I see what you mean. Yeah, because it's type 1. Yeah, but you could still have COPD and go into ARDS, right? So, I mean, I hear you. I'm going through the exercise as a way to review the class, actually, right? So, what is the PF ratio? P is 50. And the F is what? 0.21, right? What is that? 50 divided by 0.21?
238.
238. Ah. That falls in range for ARDS, right? It's less than 300. But why wouldn't you call it ARDS? Because it's type 2 respiratory failure, right? You have to use all the information given to you, right? And let me tell you something. Many times in exam, they give you information. Make sure you use it. There's a reason. Many times in exams, especially in clinical cases, they don't give you information you don't need. So if you're finding yourself not using the information that is being provided, you're probably thinking wrong or you're being presumptuous. You need to step back and take a look at it. Okay? All right. So pneumonia, there's not much we can do. It's a type 2 respiratory failure. Pneumonia is excluded in that case. Why AA gradient? Yes, because it's COPD. So the answer here is COPD exacerbation. Right? You don't need to go through all these calculations. I just went through them as a way to help you and learn to use what we talked about this morning. Okay? I think that is my last slide, but I don't know. There is extra. Okay, so which of the following is a complication of chronic respiratory failure? Good. From now on, your name is Tolu.
I didn't hear Tolu. I thought you just.
Okay, Bradley, which of these? You already answered it. So, Tolu, reduce forced vital capacity in a patient with normal FEV1 and FEV1 FVC ratio, both are normal, is highly suggestive of which of the following pulmonary conditions? Reduce FVC. What does that tell you? Restrictive lung disease. Thank you. Wendy, which of the following restrictive lung diseases is associated with an increase in residual volume? They are all restrictive lung disease, but only one or all of them is associated with an increase in residual volume. Neuromuscular diseases, exactly. Okay? This is free for all. Which of the following statement is accurate about inspiratory capacity? It is the difference of total lung capacity and functional residual volume. It is the sum of tidal volume and inspiratory reserve volume. It is the difference of vital capacity and expiratory reserve volume. All of the above?
No, B as in boy.
B as in boy. Everybody, any dissent? Anybody dissent?
You said B, right?
You said B. Is that everybody? The class agrees?
Yeah.
It's not a difference of total lung capacity and functional reserve volume. Inspiratory capacity is not a difference. Inspiratory is not the difference of total lung capacity and functional reserve volume. Remember, total lung capacity is everything, right? Functional residual capacity is the volume of air that is left after a normal expiration, right? Plus expiratory reserve volume and tidal volume. If you take inspiration, if you breathe in from normal expiration to the maximum lung capacity, that is inspiratory capacity. So it is really a difference of total lung capacity and functional residual capacity. Yes, the answer is all of the above. I need you to kind of like get that lung volume thing down. And it is not difficult. Just think about it. Think about it. Begin at the tidal volume. In and out, in and out, in and out. From tidal expiration to maximum inspiration is your inspiratory capacity. Okay? From tidal inspiration to maximum inspiration is your inspiratory reserve volume. From tidal expiration to maximum expiration is your expiratory reserve volume. What you can't get rid of is your residual volume, right? From tidal expiration and expiratory reserve volume plus residual volume is your functional residual capacity. Okay? So, inspiratory capacity, of course, is the difference of total capacity and functional residual capacity. Pay attention to that. I test it all the time, I think, and I believe you need to know it. Thank you.
So when we're doing ARDS and we calculate the P to F ratio, yeah, if it's greater than 300, which means that it's not ARDS.
It's not ARDS. That means
what's our next step?
If it is not ARDS, that means it's in one of those big units.
Okay,
yeah.
All right.
That's why you do chest x-ray, spiral CT, you do for embolism, for pneumonia, stuff like that. Yeah.
We didn't have to